We were waiting for you to start, Amna. Hello.
Yes, ma'am. Please start, ma'am.
दरवाजा बंद करो.
अभी नहीं वेट करो जब तक मेरा केस स्टार्ट नहीं होता स्लाइड शेयर नहीं होता.
You are not attending Guru.
Good afternoon and welcome to the second and the final day of the two-day Gurukul classes organized by the Institute of Obstetrics and Gynecology, Sir Gangaram Hospital, Delhi, under the aegis of ISOPAB Delhi chapter. We are once again thankful to the office bearers for having Jagsonpal Pharmaceuticals Limited as academic partner for this academic feast. Jagsonpal Pharmaceuticals presents Lycorate Reg sachets of L-arginine lycopene and DHA to prevent pregnancy complications. Injection maintain of hydroxyprogesterone caproate 250 and 500 mg to prevent preterm birth complications, and Endoreg Dynogest 2 mg tablets for endometriosis and endometriosis associated pelvic pain. We welcome the esteemed faculty present with us today. Welcome, dear attendees. Please post your queries by the text in the Q&A box. We are pleased to welcome Dr. Mala Srivastava, Senior Consultant and Professor, Gangaram Institute for Postgraduate Medical Education and Research. Ma'am is ISOPAB Vice President-elect. We now request Dr. Mala, ma'am, to please initiate the program.
Good afternoon, everyone. I welcome you all for the second day of Gurukul classes organized by Institute of Obs and Gynae, Sir Gangaram Hospitals under the aegis of ISOPAB Delhi chapter. I'm sure all the students have learned a lot yesterday, and I'm sure even today, everyone will have a great learning session. We are very lucky to have experienced teachers from all over Delhi as well as all over India to guide our students. And I'm sure every student is going to learn a lot from today's case presentations, lectures, instruments, and all the didactic lectures. We have a very vibrant, young, energetic, intelligent Master of Ceremonies, Dr. Ila Sharma and Dr. Renuka, who are going to handle the scientific session very efficiently. Dr. Ila Sharma, she is an associate consultant in minimal invasive gynecological unit of Sir Gangaram Hospital, and she has been co-editor of AOGD 2021. Whereas Dr. Renuka Bridgewal, she is also the associate consultant, Institute of Obs and Gynae, and she is a member of Urogynae Society of AOGD. I hand over the floor to carry on the scientific program.
Thank you, ma'am. I start with this note. Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Param Brahma, Tasmai Shri Guruve Namah. I welcome all my teachers and esteemed students for this second day of Gurukul. And without delay, we start with the proceedings. First is the case presentation by Dr. Gurpreet Kaur. She will be presenting a case on recurrent pregnancy loss. I would like to invite the moderators. Dr. Kamal Gujral, who is a, am I audible?
Yeah.
Yeah, who is our chairperson and head of the department of the Institute of Obstetrics and Gynecology and a very eminent teacher. I welcome you, ma'am. Dr. Asmita Rathore, who is director, professor and head of the Obstetrics and Gynae at Maulana Azad Medical College, New Delhi. Good afternoon, ma'am. And Dr. Renuka Brijwal, who is associate consultant at Sir Gangaram Hospital and a member of Uro-Gynae Subcommittee AOGP. Over to you, ma'am. Over to you, Gurpreet. You can start the case.
Okay, ma'am. Thank you, ma'am.
Share your slides.
Yeah, please start sharing the slides.
Good afternoon, everyone. I'm starting with my case presentation. Mrs. X, 35 years, housewife by occupation, gravida 4, abortion 3, wife of Mr. Y, 39 years old, works in railway, resident of Dwarka, Hindu by religion, belongs to low middle class according to modified Kupuswamy scale. Presented in gynae OPD with history of UPD positive at home, overdue by 2 days with history of 3 consecutive spontaneous pregnancy loss. Chief complaints. She presented in gynae OPD with history of UPD positive, overdue by 2 days with history of nausea. Menstrual history. She attained menarche at 13 years of age. Her menstrual cycles were regular, 4 to 5 days, 30-day interval with normal flow. Her LMP was 14th of January 2022 and her expected EDD is 21st of October 2022 and her POG is 5 weeks 1 day. Obstetric history. She is married for 5 years. She got married in 2017. She's gravida 4, abortion 3. History of abortion 1 in 2018. She conceived spontaneously after 1 year of marriage. She did her UPD after 10 days of overdue, which was positive. At 6 weeks, she had bleeding PV with passage of clot. She went to some government hospital for checkup and informed that she aborted completely. History of second abortion in 2019. She conceived spontaneously. She did her UPD at home after 1 week of overdue, which was positive. She went to hospital. Folic acid was given to her. After 5 weeks, USG was done, reported intrauterine pregnancy with no cardiac activity. Informed to follow up with USG report after 2 to 3 weeks, but a week later, she had a history of bleeding PV. She went to hospital, POCs at OS, suction and evacuation was done, and POC is not sent for examination. In between, according to patient, she was investigated in some government hospital. According to patient, her reports were normal. History of third abortion in 2020. She conceived spontaneously. She done her UPT at home after 2 days overdue, which was positive. She went to hospital. She was started on folic acid, progesterone support, and ecosprin. USG was done at 6 weeks. Cardiac activity was present. She had history of spotting PV and brownish discharge at 10 weeks. Repeated scan was done, suggestive of no cardiac activity, and she was medically managed. Past history, there's no history of diabetes mellitus, hypertension, asthma, or any thyroid or any cardiac disease. There's no history of intake of ATT, no history of DBT or CVA, no history of any surgical intervention. Family history, there's no history of diabetes, hypertension, and bronchial asthma, or any anomaly in the family. Personal history. She is vegetarian by diet, normal sleep and appetite, normal bowel and bladder habits, non-alcoholic and non-smoker. Partner history. The age of partner is 39 years, who works in railway, non-smoker, non-alcoholic, no tobacco chewing, no history of any chronic medical or surgical illness. And on general physical examination, patient is calm, conscious, cooperative, and well oriented to time, place, and person. Built and nourished. Her height is 160 centimeter and weight is 73 kg, and the BMI is 28.5 kg meter square. Afebrile to touch, and pulse is 76 per minute. Taken in right radial artery, good volume with no radial or no radiofemoral delay. BP is taken in right brachial artery, 116 by 70 millimeter of mercury in sitting position. Her respiratory rate is 18 per minute. She is moderately built and moderately nourished. There's no signs of pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Bilateral breast normal and thyroid is normal. On systemic examination, on serious examination, S1 and S2 hurt, no murmur. On respiratory examination, normal vesicular breathing, air entry present and equal on both the side and no added sound. On abdominal examination, on inspection, abdomen is normal, umbilicus is inverted, odd quadrant moving equally with respiration, no scar mark, no dilated veins, hernial orifices normal. On palpation, abdomen is soft, non-tender, no organomegaly. External gelatiria is normal. On PS examination, cervix, vagina normal, there is no discharge. On PV examination, uterus is just bulky, soft, anteverted, bilateral fornix free. And my provisional diagnosis is 35 years, gravida 4, abortion 3, with period of gestation 5 weeks, 1 day, with recurrent pregnancy loss under evaluation.
Get off the slides. Dr. Asmita.
So, what are important points on history which you feel are important, and you will give you some clue as to the possible causes?
Ma'am, I'm not able to hear you, ma'am. The volume is very less, ma'am.
Slides are done.
What are the important points in her history which you feel are important from the perspective of finding out the etiology in an individual case? Though we know that it around 50% cases, we will not find any etiology, but we should be very vigilant while taking the history to find out the probable causes. So,
According to the
history,
ma'am, according to the history, ma'am, she had abortion, ma'am, before, ma'am, all the abortions before, ma'am, 10 weeks, ma'am. It's consecutive 3 spontaneous abortion, ma'am.
No, Gurpreet, ma'am is asking what history leads you to the etiology, some idea about the etiology, what can be that in your history? What are the points?
Ma'am, first is the abortion is, ma'am, before the, ma'am, it's spontaneous, like 3 spontaneous, ma'am, before 10 weeks, ma'am, which suggestive of, ma'am, APA, ma'am. And, ma'am, the age of the patient as well, ma'am, which is 35 years, ma'am, and the partner is 39 years.
So, see, I mean, from the history, you can say AP, you can think of it, but you have to rule out all the other causes and not make hormonal, genetic before you label a patient as APO. But yes, we take her point that with 3 losses before 10 weeks, right? So at this stage, now at 5 weeks of pregnancy, with this history you give, what tests you will do besides the routine pregnancy test? Don't mention blood group, etc. Besides the routine pregnancy test. At this stage, 5 weeks she's come to you, you find a soft bulky uterus dating. What tests now will you do specifically in view of her history? Or what tests besides the routine pregnancy tests?
Ma'am, first, I would like to, ma'am, do the ultrasound to know whether it, to find out the G-sex, whether it is intrauterine or to confirm, ma'am. Then I would like to screen for the, ma'am, APA, ma'am.
Straight away.
Ma'am, the screening, ma'am, for screening of the APA and, ma'am, the thyroid profile as well, ma'am, in this patient, ma'am, to look out any endocrinology cause, ma'am.
That's it.
And, ma'am, GTT, ma'am, GTT.
So GCT or GT, whatever you want. Her BMI is 28.5. So thyroid diabetes is the first thing you just rule out, So if you do so-called APA, what are you going to order? Just write APA.
No, ma'am, I would like to write, ma'am, anti-cardiolipin antibody, IgG, IgM, lupus anticoagulant, and anti-beta 2 glycoprotein, ma'am, IgG and IgM. It should be, ma'am, on 2 occasions, 12 weeks apart, ma'am.
So you don't have time now for 12 weeks apart. Now she's already pregnant and you've got to take very quick decisions. So my question to you is that you've done these 3 antibodies these three profile, the beta 2 GP1 lac and ACL. Can you predict her risk when the test report arrives to you?
Yes, ma'am.
Her risk, yes.
Ma'am, according to the ma'am IgG levels, ma'am, of a phospholipid, ma'am, if it's more than 40, ma'am, it's toward the high risk, ma'am.
Is it?
And if it is the more than 99%, ma'am.
Is that the answer? Think about it. Quick, now we have to move forward. High levels we take it, but triple positivity and lupus anticoagulant. These are two main things. If the lupus is positive or she's triple positive, all three are positive, she gets into a very high risk. Do you agree with me, Dr. Smita?
Yeah. And
Dr. Smita, are you there? Kya ho gaya?
define the positive test. Can you just
Yeah.
how will you
Yes.
define the positive test?
Yes, that's true. How will she define?
Ma'am, if the two positive tests, ma'am, to be taken, ma'am, on 12 weeks apart, ma'am, there should be two positive, ma'am, values, ma'am, in the span of 12 weeks, ma'am.
You have to see how much positive mild moderate. So you already said that. Say it properly.
Ma'am, the ma'am levels of the IgG phospholipid, ma'am, more than 40, ma'am, or it should be more than 99%, ma'am.
Percentile for that.
Percentile.
Right. So you've gotten them done. Suppose now in this, you have a, let's say beta 2 GP1 positive also, and you've got a lac positive, or you've got only lac positive, right? What additional investigation you will send now? If the lupus anticoagulant is positive in your case, what additional investigation you will think of sending?
Ma'am, the inherited thrombophilia profiling, ma'am.
Inherited thrombophilia is a separate thing in itself, and it is not related to recurrent pregnancy loss that commonly.
Ma'am, ANA testing, ma'am, anti-nuclear antibody testing, ma'am.
What will that tell you?
Ma'am, if patient is having, ma'am, any other immunological, ma'am, factors, ma'am, like SLE.
So the lupus anticoagulants are part of the SLE. What test? What specific? We don't have time, mind you. 1 week you give her ANA, call her after 3 weeks, she's already had a missed abortion. You got to think very fast. So my question was, if the lac is positive, would you do some quick test also to know which will have a bearing on the pregnancy later? I've given you a hint. You said she could be a part of SLE. So what happens in SLE? What determines the risk to the baby?
Ma'am, there is a heart blockage, ma'am.
So what is that test called as? What is that antibody called as, which you just determine? Once you have a lupus anticoagulant positive, think of SLE or whatever. What is the test called as? SSA, SSB, Rho or La? Rho, La positive.
Rho, anti-Rho and anti-La.
Right. So if they are positive, what can the baby? What can she have?
Ma'am, the baby have a heart blockage, ma'am, due to ma'am, the effect of the antibodies, ma'am.
What happens to the antibodies? What do they do? What do they do? She's SSA, SSB positive or anti-Rho positive. So what happens to the antibodies? How does it cause heart block? When does it occur? Why it occurs? Dr. Smita, we leave at that and go forward. She doesn't know the answer, but these are about 16 weeks of pregnancy.
I would like you to make Gurpreet. Yes, I agree with Dr. Gujral. We move ahead. In your patient, in all three pregnancies, the cardiac activity was not demonstrated. Does that make any sense to you?
Yes, ma'am.
All three abortions she had, there was no documented cardiac activity. Do you think is there any significance of this particular finding?
when the cardiac activity was seen. Is that
Ma'am,
so?
it was seen in the ma'am second abortion, ma'am. The
Third
not
abortion.
seen
Third.
in, ma'am,
All 3 pregnancies.
No, Dr. Smita, first she was overdue and she just bled. So we don't know what happened. Second 5 weeks, SAC was,
Yeah.
see that, no cardiac activity. 5 weeks, we don't expect. Third one, you said there was a cardiac show. The third,
Yeah.
activities.
third one, please, quick. Oh, you know your history. Huh, third one,
Ma'am, ma'am, at 6 weeks, ma'am, the cardiac activity was present,
there
ma'am.
was C. Okay.
Fine.
So in one,
So
nothing was
that's a
done. In
very
second,
important point in history we need to note. Please go ahead. Huh.
yes, Dr. Smita.
Yeah. In third pregnancy, cardiac activity was present and later on that disappeared.
Yes, at 10 weeks, she disappears. At 10
Yeah.
weeks, she got this.
So what is the significance of this finding?
Ma'am, she had a missed abortion. Ma'am, the cardiac activity came and the gone, ma'am. It is suggestive of immunological cause, ma'am, most likely, ma'am.
What immunological cause?
Ma'am, toward the APM, ma'am.
Yeah. Now, suppose your patient has this APA positive, correct? We leave the lupus because you got to read that, is positive. And with this background history, what is going to be your management? You don't have 12 weeks to repeat like a classic APA definition, correct? No? So what will you do at this stage? APA positive, 5 weeks vaccine.
Ma'am, I would like to start the patient on, ma'am, low dose, ma'am, aspirin with the, ma'am, low molecular weight heparin, ma'am, to prevent the further loss, ma'am, and to prevent the good outcome in the pregnancy. And ma'am, I would like to do the dating scan as well and the screening for the preeclampsia, as APLA can lead to, ma'am, early onset, ma'am.
Gurpreet, you are at 5 weeks of pregnancy. Screening for preeclampsia is not done at 5 weeks.
Ma'am, later on, ma'am,
later on, maybe first stay here. She is 5 weeks. We are asking how will you manage? We are given as a background, she's positive, huh? Right? She's cardiolipin positive, IgG, high titers. Okay. LAC, we left it for you because you didn't read. Now at 5 weeks vaccine, what treatment would you start?
I would have to start with the
justify why you want to start heparin.
Ma'am, because heparin, ma'am, it binds with the, ma'am, beta-2, ma'am, glycoprotein. So it prevents the thrombotic event and
so that is the treatment for antiphospholipid antibody syndrome or positive antibodies. Now your tests are going to take long. Let's say 10 days your lab time is there to report. What will you do? You'll wait for 10 days?
No, ma'am, I will still start the patient on the aspirin and the, ma'am, and the heparin, ma'am, because she already had 3 losses, ma'am.
So if 3 losses, you always start heparin, or is there something else in your history which suggests that yes, you are right in starting?
Ma'am, because the losses are more, ma'am, before 10 weeks. So, ma'am, I can think over it.
But you are given a history, it's being shown on the slide that she did take ecosprin the last time.
But as ma'am, in spite of taking ecosprin, ma'am, she's maintaining her pregnancy. So I'd like to start on heparin, ma'am.
So that should have been an answer, that because the history, I don't have time. I have for the test to come. She had aspirin, she had progesterone support third time, had right from 5 weeks when she saw, and yet she lost the cardiac activity. So this makes a case, even if there's no bad obstetric history, this makes a case for you to start. Okay, you've started this. Dr. Smita, ask her now. She started heparin, low molecular weight heparin.
Okay, what will you have any other investigations, or you now have a one reason you have gotten cause for her and rest of the workup is not required?
No, ma'am, I would like to investigate, ma'am, other factors as well, ma'am.
Say, what will you do?
So what
ma'am, I would like to do the thyroid function test and the anti-thyroid antibodies and ma'am, HbA1c and glucose tolerance test.
Glucose challenge, you can say. Tolerance may not
tolerance test at 5 weeks you want to do?
No, ma'am. Ma'am, I will like to do ma'am HbA1c, ma'am.
Don't test for sugars and you can give a GCT. That's a recommendation society every trimester. What else?
Ma'am, serum prolactin level, ma'am. In cases, ma'am, it can be
rationale for doing that.
अब उसकी क्या value है serum prolactin की pregnancy में? And what will you do? Will you start a drug for it? No. So what is the value of prolactin at this point of time? क्यों Dr. Smita?
Yeah, I agree, completely agree.
There's no value of serum prolactin at this point of time.
No.
And if a patient had a history of a family history of like inherited thrombophilia, then I would like to go for screening for inherited thrombophilia if patient had history of a family
It
thrombophilia.
doesn't have, na? In any case, treatment is again the same what you're starting, no?
Yeah.
So once you start, what are the further management?
Ma'am, first we'll counsel the patient, ma'am, regarding about the
Go on. Counseling is the most important part in her case. With being had 3
What all
doses.
will you counsel?
Yes, I would say it's of importance to tell her.
ma'am, in counseling, I would like to, ma'am, tell the patient that there is a good, successful outcome in spite of having 3 abortions, like 70 to 75%, ma'am, and give her, ma'am, reassurance to the patient, ma'am, and lifestyle modification if she is obese to reduce the weight or to say the smoking and all the factors, ma'am.
Please, when we take a case, no, you have to do
Focus
this.
on your case only.
You said non-smoker, non-alcoholic, तो फिर आप quit smoking, start and quit थोड़ी होएगा, है ना? So you please be specific what Dr. Smith has asked you. You said you'll just tell her that there's a good chance that she'll continue. Would you not like to tell her that, look, you've got these positive antibodies, you know, and this makes a sense for me to start an injection every day. It does prevent in this number of percentage of cases, the successful outcome is in that much percentage. How much percentage of cases?
I mean, 70 to 75%.
Yeah, it's a good chance that, and you got to take the regularity of the injection. That is very important once you have started. What else now you do? Next step.
Ma'am,
Low molecular heparin, which doses?
Ma'am, I'll start with the prophylactic dose, ma'am, 40, ma'am, once a daily, subcutaneously.
1 milligram per kilogram once a day. Okay. Now, what is the next step? At 5 weeks, you've started folic acid, you've started this. Would you give some progesterone support? Yes or no?
Yes, ma'am, I would like to give progesterone support, ma'am.
More often I
What
watch.
is the
But as
justification
there
for
is,
that?
Yeah. Yes, ma'am. Yes, Dr. Smita.
What is the justification for that?
Yeah. There's hardly any.
ma'am, she had losses and to maintain, to give the additional effect, ma'am.
No, Gurpreet, we have to talk in terms of evidence. What level of, if you want to give it as an empiric theory, you want to give it as some level of an evidence, you should always justify an exam why you are giving it. Even if you are giving it an empiric, say, I will give it as an empiric therapy. You have to be clear what is the rationale in giving that medication.
Gurpreet, on the ultrasound.
Ma'am, just empirically, ma'am.
Okay.
We'll give the progesterone empirically, ma'am, not.
Evidence doesn't support it, correct? Unless you know about it. Now, my question was, you asked for an ultrasound. You did say in the beginning, first thing you do is an ultrasound to confirm the intrauterine pregnancy. Then only you'll start the heparin, etc. Now, can you look at the ultrasound and mentally think, yes, this pregnancy is going to continue or not going to continue? A 5 weeks ultrasound.
Ma'am, look for the
1 or 2 days, huh? Bolo.
Ma'am, look for the ma'am GSAT, ma'am, and the
GSAT to hai.
And ma'am, the look for the cervical length, ma'am. Whether
Will
At
the first
5
semester
weeks.
board come at a cervical length?
At
I
5
asked you the
weeks.
ultrasound to give prognosis to the patient. I mentally think, don't tell her, just think that yes, she's going to carry or she's not going to carry.
ma'am, she should carry.
What are
Maine,
the points
my
on
question was ultrasound.
ultrasound which are the good prognostic factors?
Yes, in other words, she's put now in your mouth. What are the good prognostic factors in the ultrasound?
Oh.
Chat box में आंसर लिखा आ गया, तुम पढ़ा नहीं है, चलो.
Double
See, sac dating,
double deciduous.
sac not oligoamniotic, sometimes shriveled small sac that will not grow, a good trophoblastic reaction, a normal looking yolk sac, thick yolk sac is not good. So these are few things, which you'll see that 5 weeks more than this you can't. And of course, any bleed, subchorionic bleed already there, then you are in for trouble. Okay, it's already answered from the chat box. Anyway, now what next? How will you follow her up now? Basic investigations, okay. Thyroid profile normal, sugars normal, and you've started this particular treatment for her because of her cardiolipin and beta-2 GP1 positive. How will you go forward in her now?
Ma'am, antenatal ma'am care is planned once in a ma'am. I'll call the patient every ma'am 2 weeks till the 24 weeks ma'am for her follow up ma'am. Proper screening for the ma'am for the screening of the aneuploidies ma'am.
Though of them is every 2 weeks in the first trimester. Why?
Ma'am, it is a ma'am high risk pregnancy ma'am.
So what will you do by calling her? You have to repeat an ultrasound after a little while.
Ultrasound.
Cardiac activity comes or not, whether the pregnancy grows okay or not. This is the follow-up now.
Because she previously had a history of cardiac activity present, and after some weeks it's gone. So I would like to do the repeated scan to look for the cardiac activity again. And
repeated or repeat? Repeated or repeat?
Ma'am, repeat.
And at 5 weeks, you'll repeat at what time?
Ma'am, between 6 to 7 weeks, ma'am. Again.
So 7 weeks plus 8 weeks, you repeated cardiac is there. Then?
And ma'am, then ma'am, normal routinely, ma'am, we call the patient, ma'am, after 1 week to follow for the ma'am screening for aneuploidies, ma'am.
When will you screen her for aneuploidy? How will you screen? What time will you do that?
Ma'am, not able to hear you, ma'am.
At what time will you screen?
She's asking you, when will you screen for aneuploidy?
Ma'am,
at what period of pregnancy?
Ma'am, at 11 to 13, ma'am, 11 to 13 plus 6 weeks, ma'am.
Right, no? So 11 to 13 is the time. So if you got a cardiac at 7 weeks or 8 weeks, tell her at this particular time you are fine, and your next ultrasound would be at this particular, this will tell us certain very informations. You're not going to call every 2 weeks to see a cardiac activity. Whether if it's a bad luck, if it's not there, it's not there. You can't do anything else now. You've already started treatment.
Okay.
Now that you've answered 11 to 13 weeks, what will you do?
Dr. Gurukul, is there any role of beta HCG in this patient? Injectable HCG?
Ma'am, inject beta HCG level, ma'am, you're talking about?
She's asking about HCG injection HCG. As a support.
Ma'am, that ma'am, because it reduces the level of beta HCG, ma'am, the pathogenesis, ma'am. You see the pathogenesis of APA, ma'am, it reduces the level of ma'am.
Again, Gurukul, I come to the question, is there any evidence in benefit of giving HCG? And my second question will be, will this administration of HCG modify in any way the aneuploidy screening that you will be doing in this patient?
Okay, Dr. I think she doesn't know. Is there any role of SCG? Yes or no? Answer chat box is already saying the answer.
Ma'am, no, ma'am.
No.
It's not
And if you give it,
all right, there is no
आपकी मर्जी है, तो
support.
answer our second question. Since Dr. Asmita's voice is not that clear, her question is that will SCG modify anything which you're going to do now at a little later stage?
Ma'am, I have no idea.
What is when you do an aneuploidy screen, what are the serum markers you see in the aneuploidy screen?
Ma'am, it's a serum beta HCG and ma'am, PAPE, ma'am, in the first trimester screening, ma'am. Ma'am, it also.
So if you HCG, so in a down baby, what is low and what is high?
Ma'am, the serum beta HCG is high and PAPE is reduced, ma'am.
Right. So but Dr. Kasmita's question was that will it affect? Yes, it will affect. What is the half-life of beta HCG?
Ma'am,
IVF में भी काम कर रहा है. I think 48, 72 hours.
40.
Yeah, so be careful in that you don't give it. You have to write that you're giving it. Okay. Already 36 hours is written. Somebody's very intelligent. Now what next? You'll do the aneuploidy screening. You said.
Yes, ma'am. And ma'am, further, I would like to do when the pregnancy further increases, I would like to call for the.
1 minute. What do you see on the ultrasound for the aneuploidy screening?
Ma'am, we'll see for the soft markers, ma'am.
Soft markers at 11 to 13 weeks.
13 weeks scan. What do you look for?
एक single answer आपको आना चाहिए गुड्डी.
Ma'am, I'm not able to hear. Ma'am, I'm not. The voice is breaking, ma'am.
Are you able to hear me now?
Ma'am, I'm able to hear you, but I'm not able to hear Asmita, ma'am.
I'll repeat her question. She said, what will you see in the ultrasound for a aneuploidy screening? Which is a single
Nuchal translucency in the nasal bone, ma'am.
Nuchal translucency and the second is in nasal bone. So फिर बाकी soft markers तो भी नहीं आए ना. There are many other ways to predict, but these are two main ones. Anything else you can see?
Ma'am, these both things, ma'am, in the first trimester with the ma'am.
Chalo, even if you don't know tricuspid regurgitation, ductus, etc., you can leave. But
and right aberrant, ma'am, subclavian artery, ma'am, and ductus.
Leave those rare things now. You tell me, can anything else? बस वही देखोगे first trimester के ultrasound में 11 to 13 weeks, or you can see.
Ma'am, cervical length between 11 to 12 to 14.
Cervical length तो later part है. इसका तो कौन सा Mr. Boschno है? She's like in Ali only for us. This is surface anatomy. Your answer should be surface anatomy. About 70% of birth defects can be seen, like in
anatomical defects.
So many. So surface anatomy, whatever is possible at this particular time, is it normal or not? You can go home and read what all you can see, 10, 11 things in the, first trimester ultrasound. Okay. Now you've crossed the thing. Fortunately, you're fortunate that she's got a cardiac activity. And then you should also see any retroplacental area or subchorionic hemorrhage all along. Right? Now, what is your next step? You gave her folic acid, you gave her progesterone, you gave her ecosprin, you gave her low molecular weight heparin. And you've done a 11 to 13 week scan, which is normal, low risk for aneuploidy. What further will you do?
Ma'am, then further, ma'am, I would like to do the ma'am anomaly scan, ma'am, between 18 to 20 weeks to rule out any malform, any lethal abnormality or any minor abnormality. And
Dr. Gurpreet, do you think you need monitoring of her low molecular weight heparin in any way? It needs to be monitored?
Ma'am, it's just a prophylactic dose, ma'am. So one just baseline, ma'am.
If you were to see, what would
to
you
be
see?
considered.
If you're to see, आप करना है तो क्या करोगे?
Ma'am, I will like to take the ma'am baseline platelet count, ma'am, because anti-tenant factor usually will not do, ma'am.
Okay, baseline
Platelet
मैंने
count.
देख लिया. But if you have to specifically monitor this particular low molecular weight heparin, you have to monitor, like Dr. Asmita is asking you, what is that lab test called as? Normally, it doesn't need monitoring. We agree with you. You got a
Yeah.
We agree with you. Will you do PTA, PGT?
Ma'am, that usually for the unfractional heparin, ma'am, will
So
do.
say I will not. That's your answer. So if I say नहीं भैया तूने तो एक टेस्ट करना ही करना है तो क्या करोगे?
Ma'am, baseline platelet for the low molecular weight.
वो तो हो गया. We've given
वो
it.
तो हो गया. Anything else? Rather, what is the specific test for monitoring low molecular weight heparin?
Anti-10 factor, ma'am.
But that's what we wanted you to answer that.
Yeah.
That's what we wanted to. If you have to monitor, it is that level. Otherwise, it doesn't need any monitoring.
Monitoring.
Yes.
First.
So further on, what will you do now? Your anomaly scan is normal.
And then the fetal surveillance, ma'am, I will test after 28 weeks, ma'am, for the fetal surveillance and the ma'am for the growth scan with Dopplers, ma'am.
When you began the case, you kept on saying screening for preeclampsia. When we reached 12 weeks, we forgot the screening for preeclampsia. So that is a normal part.
To look for the uterine artery, ma'am, prediction Dopplers, ma'am.
Can
you add any other marker to your biochemistry when you are screening her in first trimester? She's already 30. She's a 39-year-old woman.
And also BMI is high, so she runs a risk.
And plus she's APLA positive.
Yeah.
Ma'am, the Doppler studies, ma'am, with the scanning, ma'am, to look for the uterine artery, ma'am, Dopplers, ma'am.
What is the value you're going to look at? Yeah.
Ma'am, ma'am, notching, ma'am, bilateral notching, ma'am, if the present.
That's obsolete. Chalo, mean uterine PI, and Dr. Smita was asking you for a marker along with that.
Ma'am, you're asking for which marker, ma'am, not.
Preeclampsia prediction में क्या करोगे? जैसे aneuploidy prediction है, PAPA, beta estrogen, nuchal transfer, add nasal bone, maybe other markers. Okay. Preeclampsia prediction में what are you going to do?
Ma'am, the other markers are, ma'am, placental, ma'am, growth factors.
Yeah.
And so. And ma'am, with added maternal age also, ma'am, prediction of.
So what does it involve?
And soluble FM.
It involves maternal
and
age,
uterine artery PI, mean
pressure, mean uterine PI, PIGF, PAPA, and the risk is calculated. If you don't have PIGF, you can do PAPA only also. Yeah. So if it's a positive screen, then what do? Assuming her screen was positive, what is the next thing? Assuming it is positive, screen positive, 1 in 50. Okay. So क्या करोगे?
Ma'am, as I already started patient on the ecosprin, ma'am. Further,
what is the dose?
What
is the dose of ecosprin?
Ma'am, we'll give the 75 mg, ma'am, in the.
What does aspirin trial say? How much of aspirin for preeclampsia prevention?
Ma'am, for the preeclampsia, ma'am, we'll give 150 mg, ma'am, to prevent the preeclampsia.
So you can increase because our screen is positive, you're justified to increase. Okay, now you have reached the 28 weeks. What did you do now?
Ma'am,
any other point would you like to see in her anomaly scan? Something else will you look at when you do her anomaly scan? You have done anomaly scan, you have done uterine artery Doppler. Anything else can be done?
Ma'am, in second trimester, we look for cervical length as the cervical length, ma'am.
Yeah, so that also should be a part of your routine screen.
Which you are doing in first trimester, hai na? So you should not, this is a 24 weeks.
12 to 14 weeks.
Yeah. 20 to 24 weeks cervical length, not at 12 weeks. Okay. You can relook at the Doppler. If the Doppler flow, uterine artery Doppler has become better, improved, then your chances are better. If they are still high resistance, more than 95th centile, that means you're bound to get some complication like a preeclampsia, growth restriction, etc. Okay, 28 weeks. Anything additional you'll do?
Ma'am, for the fetal surveillance, ma'am, the growth scan and the Doppler, ma'am, I would like to do, ma'am. Fetal sur- Every, ma'am, 3 to 4 weeks, ma'am, the growth scan the done, ma'am, after 28 weeks, ma'am. Fetal surveillance was, ma'am, I would like to done fetal surveillance after 28 weeks, the gap of 3 to 4 weeks, ma'am, for the growth scans, fetal growth scans.
So
What is her risk of developing fetal growth restriction?
We are almost reaching the end. Please go on skipping your answers.
Indirectly, we want to ask you, what are the problems you anticipate in a woman with antiphospholipid antibody syndrome?
Ma'am, it leads to, ma'am, frequent pregnancy losses and preeclampsia and IUGR.
Yeah, it's an early onset
Early onset
preeclampsia and early
IUGR.
onset
FGR.
fetal growth restriction. Yeah.
Yeah. Not to forget your diabetes screen at the right time, what you should be doing. You've done it first, not to forget that. That's a part of normal thing, normal antenatal care. So, she said she'll do 4 weekly, 3 weekly scan. What are you going to look at it? You've done a 28-week scan. Now at 31, 32, you have repeated. What is important for you to see, identify growth restriction?
Ma'am, to look for the weight and, ma'am, the Doppler, ma'am, as well, ma'am, the umbilical arteries, ma'am, and the serious growth, ma'am, whether
how do you see the growth? That was my main question.
By seeing the, ma'am, abdominal circumference of the, ma'am, in the USG, ma'am.
Okay, abdominal circumference, fetal weight, headlock formula, but my question was again not answered. At 28 weeks, what is the growth you're going to look at and how are you going to follow it 3 or 4 weeks later? What is FGR? All right, growth less than?
Ma'am, less than 10 percentile, ma'am.
Fine. So my question was, you form a baseline growth that she is at what centile? She's at 20th, 25th, 30th, and then 4 weeks later when you're doing, has the growth centile fallen? This fetus was at 25th centile, now suddenly it's become 15th, I'll be worried. That means growth is not occurring. That is what we wanted to say, along with Doppler flow, amniotic fluid, and everything. Chalo, you're monitoring growth. She's all right. She's maintained her growth. Dopplers are okay. Now, when will you deliver her?
Ma'am, ma'am, at, ma'am, 38 weeks, ma'am.
We can.
Ma'am, but first, ma'am, before delivery, ma'am, I would stop the, ma'am, icosapent 36 weeks, and 24 hours before, ma'am, I would like to stop the heparin, ma'am, and I'll give the trial for the vaginal delivery if there is no other complication besides, ma'am.
Asmita, I'll agree to it. So, and then
proper regular monitoring, ma'am, during the labor.
You take her to 38 weeks or 39 weeks, you want to induce her, fair enough. You do a CTG monitoring, fair enough. And stop heparin at the right time. And then what will you do now? Post-delivery or post-operative, kya karoge?
Ma'am, as she had no history of, she had just no history of any other risk factor for giving thromboprophylaxis. Because APLA can lead to thromboembolic event, ma'am. So,
So-
I'd like to give for 1 week, ma'am, of the thromboprophylaxis for the 1 week.
Is that the evidence? Is that the evidence? 1 week?
Ma'am, the evidence only for the intermediate risk, ma'am, only. If the patient have any other associated risk factors, then for the 1 week. As she's
This answer, Dr. Smita, I'm not okay with this answer.
Yeah.
See, the guideline is very
Yes.
clear. Bolo aap.
Yeah, you should assess the patient at the onset of labor for risk of a thromboembolism, and she may undergo cesarean, she may develop some other factors. So you have to do a risk scoring and then decide when and how much to give. All right. It's not only blanket,
will fall in
all
the
APLAs
risk.
you give for 1 week.
She will fall in the risk. Her BMI is more. You had an operated.
Yeah, age
She'll be
factor is
positive,
there.
100% she'll be in the risk. Yeah.
and she's
Yeah.
overweight.
Late age also, 35 plus.
Age also,
you know.
yeah. And if she
Age,
ends up with a
BMI,
cesarean, it will
APLA
be
positive.
further worsened.
So if we decided that she needs to be given for how long, as per the guideline in case of APLA positive. If you decide postpartum thromboprophylaxis for how long, 1 week is not the answer.
Ma'am, in the high-risk patient, we give up till 6 weeks.
6 weeks. The
Yes,
recommendation is 6 weeks.
6 weeks.
6 weeks. That is what 6 weeks. Now, suppose this patient of yours, this patient of yours also had a history of thrombosis sometime in the past. What is the change in the management? Your patient APLA positive, RPL, you've given heparin, you have continued risk factor, postpartum finished. Now, your patient now had a history of thrombosis in the past. With this background,
Ma'am, I would like to modify the dose of heparin. Ma'am, I will give the therapeutic dose.
that's what we wanted to
20
do.
mg, ma'am, twice daily.
And then after delivery,
Ma'am, to continue up till the 12,
what?
up till 12
What?
weeks.
It's only, she's added thrombosis in the past. Ideally, these women are already on the, your acetrom and all, warfarin
Yeah,
already stopped and changed on. And it's a lifelong, mind you, because this one, can you give her warfarin now? After bleeding, feeding, everything is okay. Delivered her. Can you give her warfarin?
Yes, ma'am, we can give warfarin, ma'am.
Does it go in the breast milk?
No, ma'am, it is safe during the...
So you can maintain her on warfarin as per the guideline. Okay? In how much percentage of women, because I know you read APLA, so let's ask you a question, you'll know. In how much percentage it's just positive in population without any obstetric morbidity?
Ma'am,
You have no problem, but yet you're carrying an antibody.
ma'am, 15%, ma'am.
15.
Ma'am, in the RPL cases, ma'am, in general it's 5%.
2%
2
general
5,
population.
yeah.
5%.
Well,
2 to
they have
5.
no obstetric problem at all, yet they are positive. You understand? You can just carry it without being. So if an APL carrier without any obstetric history comes to you, what will you do?
Ma'am, if
She has no problem. She is para 1. By some hook or crook, you just did the APL and it is positive. You have confirmed at 12 weeks. Just a positive key definition, it is positive. What will you do now?
Ma'am, I will start with the ecosprin, the low molecular weight heparin, the prophylactic dose.
Will you not?
Ma'am, I will.
Well, you can be on ecosprin.
What is the definition of APLA syndrome?
Yes. Antibodies and syndrome, both are separate.
Ma'am, antibodies are formed against the negatively charged phospholipid which are present in the on the syncytial trophoblast. So which lead to thromboembolic event, and it also alter the differentiation and the function of the trophoblast.
Now, our question is, how do you define APLA syndrome?
Ma'am, it includes obstetric.
Is only lab report enough to diagnose?
Ma'am, it
and start
includes
the
the
therapy?
obstetric and the vascular events, ma'am. The obstetric events and the vascular events, ma'am. The obstetric events includes one or more fetal demise, morphological normal fetal demise after 10 weeks, ma'am. And
Okay.
3 or more consecutive spontaneous losses before 10 weeks without any maternal factors.
So the message is that only positive lab is not an indication for therapy. You need some clinical criteria also to call it a syndrome and start her on the therapy, right?
Yes, ma'am.
You can give her aspirin, and as per the guideline, you don't have to.
Yeah. Aspirin you can give, but not heparin.
Yeah. Not aspirin you can give. Now, suppose this patient was Epla positive and she had a preterm delivery, your third criteria for the Sydney criteria. You said 2 already, na? The death
Yes,
you
ma'am.
said after 10 weeks.
And
This is
before
already
34 weeks.
preeclampsia. Preterm delivery before 34 weeks
34 weeks.
because of placental cause. Yeah. So suppose this patient had one history like that. One child before 34 weeks, she delivered preterm, and now she came to you. You got the same picture, no abortions, just one child before 34 weeks.
Ma'am, and the laboratory test is also negative, ma'am.
No, she's Epla positive. तभी तो कह रहे हो. 3
Ma'am,
scenario होएगा ना. Your case, your case है उसमें. या history of thrombosis है. You already said therapy. या 34 weeks से कम उसकी delivery हुआ preterm because of placental insufficiency, small baby.
I would like to give ecosprin, ma'am. Ecosprin and the low molecular.
You'll give her only ecosprin. No need of heparin.
Heparin.
There's just preterm delivery. You'll give ecosprin. And postpartum?
Ma'am, postpartum, ma'am.
सब में ecosprin postpartum देना है, तो इसमें भी दोगे और क्या करोगे?
Ma'am, postpartum ecosprin, तो ma'am will stop, ma'am. We won't give ecosprin post.
Epla positive, you are continuing ecosprin. You don't stop ecosprin.
Ma'am, ma'am, you're talking about postpartum, ma'am. What I will do in this case, postpartum.
Postpartum. Now we given you scenario. Your patient had thrombosis history. You gave her therapeutic. You continued lifelong anticoagulant warfarin. Okay. Your patient was just positive with 3 losses. You gave her for 6 weeks, looking at her risk factors. Your patient had a delivery before 34 weeks. You don't want to give her heparin. Agreed. You give her ecosprin. And now postpartum. क्या करोगे इसको? Scenario है ना ये?
Ma'am will not give, ma'am, postpartum heparin to the patient. Give.
What do you say, Dr. Smita?
I think postpartum, if she is an APLA positive, postpartum can be given at least for a week or preferably up to 4 weeks.
Actually,
But
if the
again, you have
delivery
to
is
go by the
normal,
risk assessment and do the scoring.
yes.
Yeah.
You have to go for every postpartum. Otherwise, generally, if the delivery is normal, you may give pneumatic compression and all those other devices. But if the delivery is falls into high risk. That
Operative, yes. So overall risk scoring has to be done immediately after delivery also, that what is the duration of an anticoagulant therapy which she needs.
Jab dena hai, 6 weeks dena bas. That's it.
Yeah.
What else we ask her?
Yeah, I think Dr. Gurpreet, you can check the chat box if there are any questions and you can
most of
answer
our
them.
questions were answered in the chat box, but we will be happy to take them. Bolo, kya question hai? Who will tell us the chat box question?
There is one question which is not answered, that when heparin should be started, is it after the cardiac activity or before that?
No, as soon as you document intrauterine pregnancy. That's the guideline. As soon as you document, which will be 5 weeks. Ecosprin in this patient, if she would have come to me, I would have started before conception ecosprin, continued, confirmed pregnancy, and see that's an intrauterine and start.
And we can
Not
switch
after
over to heparin. And ma'am, for how
5
long
weeks once.
heparin to be given?
How long heparin if she's
That we have already discussed, no? It should be 6 weeks postpartum.
And ma'am, one more question is there, that any role of cervical cerclage or progesterone to prevent preterm labor?
It's a big topic in itself, and I don't think it comes in RPL. Confirmed incompetent os by the criteria examined mid-trimester painless abortion are, Dr. Shirodkar defined that they should be given cerclage. Then there's an emergency cerclage, which is a definition in itself. Bulging membranes you can reduce and give. Then there is a previous loss with a short cervix. Now the data is this way or that way.
Yeah.
And primary with a short cervix, only vaginal progesterone at this point of time, no circulation.
And ma'am, one more question, that any role of progesterone in RPL and any and the route? By which route it should?
You answer that. Everybody is giving progesterone.
I know progesterone HCG is being given very rampantly.
But there is
You
no
see, only luteal phase defect.
There is no
will have a
evidence to
progesterone
support
deficit.
it. Some people may use it. I
Just
mean,
giving
people
it
do use it
empirically,
as
there
an
is no
empiric
evidence.
therapy, but there is no evidence to support its use.
And there is no test to confirm a luteal phase deficiency.
Yeah.
You need a progesterone. So it's a very empirically you can use it. It's a harmless medication.
One more question, that whether karyotype should be done in such cases?
Whose case? This case, live baby है तो karyotype कैसे करोगे?
And parental karyotyping, to do parental
Parental, no.
Oh.
Parental karyotype only when the POCs. Actually, this patient should have had POCs, at the second, not at least the third time tested. If the baby had aneuploidy or translocation, then the whole, thing shifts to another cause, So parental karyotyping has only when you get a POC abnormal, like a translocation, aneuploidy, then you have to see the gamete chain, etc. Your pre-implantation gamete testing, otherwise no, not at this stage.
Or if you have all three missed abortions and there was no cardiac activity has appeared at any point of time on those cases.
Yeah. But real would be when you know the chromosome.
Absolutely agree.
Micro array of the product of conception, no more chromosome.
Yeah.
That's the line you must remember.
Then
What else?
Is aspirin to be continued in APLA positive after pregnancy?
No.
No.
Unless they've had the history of thrombosis, we already said that. If they've had a history of thrombosis, then say warfarin, and they also give aspirin along, but not for a APLA positive with the pregnancy.
And is there any role of,
Yes, what is it?
Yeah, is there any role of cell-free DNA in RPL?
Not to my knowledge. Cell-free DNA to determine what?
For what? Diagnosis.
Diagnosis of what?
Any, I think to rule out chromosomal abnormality or what?
नहीं, देखिए chromosomal abnormality को आपने aneuploidy screen करा. Based on the screen test, maybe an advanced maternal age.
I mean, if she has a screened indications,
it's nothing special for a woman who's
not otherwise.
Not otherwise.
Yeah.
And ma'am,
I
what
mean,
is
above 35, she wants it, you can do it because the test specificity is 99.9% sensitivity. So you'll say, very good, you can go for one better test, but otherwise not.
And ma'am, is there any role of torch profile?
Torch ko to ab bhul hi jaiye na, because LED lights are there. So a torch has no role in recurrent infections.
I think, ma'am, we are done with the questions.
Yeah. So I think we have already completed our time also.
Yeah. Thank you so much,
It was well presented, and thank you for the invite, Team Gangaram, Dr. Mala, Dr. Gujral. It was really a pleasure.
It's always nice to interact with you, Dr. Smita. I love to have you on the panel with me always.
Thank you so much.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, Dr. Gujral, ma'am, and Dr. Smita, ma'am, and Dr. Renuka. And thank you, Dr. Gurpreet.
Thank you, ma'am. Thank you.
For the case.
Chalo, we go on. The next is the OSCE.
Yeah. Now we come to the next session, which is an OSCE. Yeah, can we have the series, please?
Ma'am, yes, ma'am.
Yeah, I would like to invite Dr. Geeta, who is a senior consultant in the Department of Obstetrics and Gynecology, chairperson of Urogynecology Subcommittee of AOGD 2021 to 2023, and vice president of ISOPAP Delhi chapter 2021-2023. Then along with her, there is Dr. Chandra, who is a senior consultant and endoscopic and robotic surgeon, and in charge of the adolescent clinic at Sir Gangaram Hospital. I welcome you, ma'am. And Dr. Mamta Dagar, who is professor and senior consultant at Sir Gangaram Hospital. And she is also a robotic surgeon. I welcome you, ma'am, and I hand over to you to start the OSCE.
Am I audible?
Yes, ma'am.
Yeah, very good afternoon to all the viewers and all the senior colleagues present here. And we are now started with this, which is called a OSCE session, in which we will take you through different sort of pictorial and a different very short description of certain cases and exactly not the cases, a very short description of scenarios in which are in fact now an integral part of the DNB exam, that how much you are expected to know and how briefly you are expected to answer. So we start with the, can you just, move on to the next slide, please? Yeah, please change, Mr. Vinod, can you change the slide? Yeah. So basically, this is the image which I want all the to see, and just go back. Just go back, please. These are the, you can very well appreciate that these are the colposcopic images. Next slide. Yeah, you can very well appreciate that these are the colposcopic images. And here we have two questions to ask after identifying this. So I expect all the PGs to have a very quick look on all the images. You know that the essential step of colposcopy is that once we expose the cervix to the colposcope, to the colposcope after putting a cusco speculum, we clean it first with a normal saline, and then we view it under a green filter to look for any abnormal vessels. And then after application of acetic acid, we try to look for further more details in terms of the acetowhiteness, any abnormal blood vessels and all. And then at the last, application of Lugol's iodine application. So this is towards the end now, after seeing these evaluation of these four things, we have an idea that this is a normal colposcopy or an abnormal colposcopy. So having seen all these four images of a colposcopy after application of normal saline, acetic acid, green filter on the right side, sorry, the second image is the green filter, then after application of acetic acid, I would like you to see towards this arrow and just have this thing in your mind that what it is pointing at, yellow arrow and the green arrow and the blue line. Next. Next, please. Next slide, yeah. So the question is identify and label the arrows in the image. So this is essentially normal colposcopic findings, because what you can see as the image on the left is, you can see here that there are Nabothian cyst, which is by the yellow arrow, and you can see the blood vessels. You know, you cannot very well differentiate that it is very, any fine or punctated pattern of blood vessels. And the blue line, the dark blue line here is the squamocolumnar junction, which is lying outside. Here you have seen the cervix was not obscured by any blood or mucus. The colposcopic examination is adequate, and you can see the crypt openings. So it is a squamous metaplasia, and the squamocolumnar junction is lying outside. So it is a type 1 kind of a squamocolumnar junction transformation zone. So this is what basically very briefly we would like you to know in this normal colposcopic findings, and the question may come like this. The second part of the question was, can you go back, please? Can you go back? Yeah. That what is the tissue basis of acetowhiteness after acetic acid application and iodine negative Lugol's iodine application? Next. So next, please. So very, very briefly, you should know and write down that previous slide. Vinod, please don't change too frequent this thing, please, till I say. So the basis of acetowhiteness, we all know that tissue basis in cyan or malignant cells is that they have increased nucleus cytoplasmic ratio. They have increased nuclear proteins, which are coagulated by acetic acid. Hence, there is an acetowhiteness as no light is reflected back, and that is why you see it acetowhite positive, and this is the basis. The basis for iodine negative is that the CIN malignant or the columnar cells in the squamous metaplasia, they lack glycogen. And if there is no glycogen, because the glycogen is responsible for iodine uptake, there is no if the glycogen is absent. And this no iodine uptake, hence Bili negative, or this is how you interpret. Next. So hope you have understood this normal colposcopy and basis of acetowhiteness and Bili negative. Please very carefully see this, what it is. We would like all the students to have a look. I know you all can identify it, that what is it. This is, next please. The next question is identified and enumerated components. And the second part for this is, when does the active stage of labor start? Please go back to the previous slide. Yeah, yes, dear students, this is WHO Labor Care Guide, which has now been introduced by WHO. And this is in fact a WHO Next Generation Partograph, which is a revolutionary step towards individualized labor care now, which has been introduced in most of the labor wards. And it's better that we understand the components. It has 7 components. LCG, which is called Labor Care Guide, has 7 sections. The first section is the one number is identifying information and labor characteristics at admission, which takes into consideration all the patient characteristics such as name, age, parity, the time of onset of labor, when the time of onset of active labor, the time of rupture of membranes, and the risk factors, if any. Next is supportive care. As you see, the supportive care includes the presence, mention of the presence of companions, pain relief, and oral fluid, and the posture of the woman during the labor. The third is the care of the baby, which includes take into consideration the baseline fetal heart rate, the fetal heart rate deceleration, amniotic fluid, color of the liquor, the fetal position, and presence of any catheter molding. Next is labor progress. The care of the woman, which takes into account the characteristics, features of the woman, such as her pulse rate, blood pressure, both systolic and diastolic, the temperature, the urine, in terms of mention of the urine in terms of protein, albumin, or ketones. Next is number 5 is the labor progress, and the labor progress is actually you mentioned the cervix, the cervical dilatation and descent, and you plot it on X and plot it on O, with reference to the 0 station. Next is the mention of after labor progress is medications. You mention about oxytocin, you mention about the medicines given, you mention about the IV fluids given or not. And the last is the shared decision making, and you basically assess after the shared decision the plan, and you formulate the plan and document it in the file. So initially we have the WHO partograph, but now we are most of the labor wards replacing it with the WHO Labor Care Guide. Next, please. Next, please. So the second part of this question is, when does the active stage of labor start? So far traditionally we have been knowing this and thinking the active stage of the labor starts from 3 centimeter, then the WHO revised it to 4 centimeter. But now, as per the WHO Labor Care Guide, it is from 5 centimeter onward the active stage of labor start. Next. This we need to know. Next. Yeah, next question. So it is 5 centimeters dilatation. As per the WHO Labor Care Guide, the active stage of labor starts. Next. So I expect you to just have a look at this CTG. I know this is not very clear, but you can make out very well from this CTG that there is the baseline is definitely around 120 or so, and the presence of fetal heart rate variability is there, and there are constant decelerations with pickup and with most of the contractions you can very well appreciate here. And if you see, I know the pointer is not with me because I don't have the screen control with me. You can see that the peak of the contractions, the nadir, the peak of the nadir of decelerations is coinciding with peak of the contractions, and this is very, very typical of what you see is early deceleration. So next, please. Next. So I have already told you the type of CTG trace. This is early decelerations in labor, and the second part of the question was, is it pathological and cause? Yes, it is not. Next, please. This is not pathological because it is usually due to the head compression in labor, and we tend to generally ignore and keep on monitoring this CTG and look for any other abnormal features. But yeah, head compression in labor it is due to, and it is not pathological. Next, please. Next question, please. So identify this, you all know it is written here, it is ferric carboxy maltose injection, 1 gram in 20 ml. Next. So what is the indication for its use in pregnancy and how it is given? And what is Ganzoni's formula? Next, please. So ferric carboxy maltose is an IV iron formulation which is recommended for use in pregnancy in moderate to severe anemia. You tend to give it in second or third trimester, but definitely not when the woman is within 4 weeks of delivery, because you know it takes time to act. And as you have seen, it is 1 gram in 20 ml, which is 1000 milligram. And how you will give it is that you mix it with 250 ml of normal saline and you give it in single dose infused in 15 minutes. But before we have started giving it, you need to calculate that how much dose you need to give it, whether one injection of this 20 ml will be sufficient or you need to give the additional dose. For that, you need to calculate how much IV iron needs to be given. Next, please. Next, please. So just have a look on this Ganzoni's formula, that how do you calculate? So basically total body iron deficit in milligram is equal to body weight in kilogram into target hemoglobin minus actual hemoglobin in grams per liter into 0.24 plus iron depot. So we know the body weight in kg, we know the target hemoglobin if we take at 15, if we are considering the Western figures or considering here 13 grams in our scenario, minus actual hemoglobin gram per liter is very easy. We need to understand that how you are going to, you have come to this 0.24 number and how much iron depot now we are going to add, so that we know that how much iron we are going to infuse in terms of milligram. So this factor 0.24, and also about the body weight. Body weight is actually used to use the ideal body weight in overweight patients. And if the patient is underweight, you use the actual body weight. And this factor 0.24 is derived from this 0.0034 into 0.07 into 1000. And how it has come is just to understand it. Otherwise, you can write on 0.24 only, is that you need to know that the iron content of hemoglobin is 0.34%, and hence if you convert it numerically, it is 0.0034. Blood volume is 7% of the body weight, which is again 0.07, and 1000 is the conversion from gram to milligram. And because now we are going to calculate everything is milligram, so we have to basically now convert it into this 0.04. Again, how much iron depot we are going to add in terms of milligram is if the lady is more than 35 kg, which is not the case in pregnant women and otherwise. So a woman are more than 35 kg, so we are going to add 500 milligram to it. So for example, if the lady is 70 kg female with the hemoglobin of gram per deciliter per liter has an iron deficit of how much we are going to get it is 70 into, they have taken 15 as the target hemoglobin, which is because it's a Western figure which is coded here. 150 minus 80, which is the actual hemoglobin, into 0.24 plus 500 for the dose. So it is around about 1670 milligram, approximately 1700 milligram. So as I have told you that 1000 milligram is to be mixed with 250 ml of saline and then it is to be given. So if this is the dose, then you will not be able to complete your iron infusion in one go. You have to do it in 2 sittings. So this is what I wanted to mention. Next, please. This is the scenario that in a pregnant woman which is suffering from mitral stenosis, suffering from rheumatic heart disease with mitral stenosis, when vaginal delivery should not be allowed. It has 2 questions, 2 parts of this question, that and when is infective endocarditis prophylaxis indicated. So RHD with MS, whether you are going to allow vaginal delivery or not, definitely you are going to be guided by certain factors. Next, please. Next, please. So basically, vaginal delivery generally is allowed in a case of rheumatic heart disease with MS, but in situations with critical MS, NYHA class 3 or 4, and with pulmonary edema, the vaginal delivery should not be allowed. And when is infective endocarditis prophylaxis indicated? Definitely, whenever it is indicated and wherever it is indicated, you need to give it 30 to 60 minutes before the procedure. But it is not generally recommended for vaginal or cesarean delivery, definitely in moderate risk situations. As per ACC and AHA, American Heart Association guideline, it is only for high-risk situations. And what those high-risk situations for cardiac diseases for infective endocarditis are with women with prosthetic valves, previous endocarditis, complex cyanotic heart diseases, and surgically constructed shunts or conduits, or the patient with cardiac transplant, where infective endocarditis prophylaxis is indicated. While the moderate risk factors for infective endocarditis are most other congenital cardiac diseases, those rheumatic valvular heart diseases, hypertrophic cardiomyopathy, COMP, mitral valve prolapse with regurgitation or thickened leaflets. So having said that, we basically need to know that which regime we are giving. We can give IV. It is a mention that we can give oral also infective endocarditis prophylaxis. This is additional information for your sake I am giving you, because you can give oral also, which the recommendation is now. And this high-risk per oral regime is when the patient is not allergic to penicillin, you are going to give amoxicillin 2 gram IV, or cefazolin or ceftriaxone 1 gram IV. If the woman is allergic to penicillin or ampicillin, you are going to give clindamycin 600 milligram IV. And as far as the high-risk per oral regime is concerned, if she is not allergic to penicillin, definitely amoxicillin 2 gram per orally. And if she is allergic, then you can give cephalexin 2 gram orally, clindamycin 600 milligram, or azithromycin 500 milligram. So now I will hand over to Dr. Chandra for further. She will take you through further OSCE scenarios. Yeah, Dr. Chandra, thank you.
Thank you, Dr. Mamta. Thank you very much for a great discussion. And I don't know, students, they could understand something or not. Are you attentive? Yes, ma'am, they are answering also in the chat box. Okay, great. So yeah, so I'll take you through the few more important scenarios. And the first scenario and first and second scenario about the HIV positive mother. So this here, the priming gravida with 10 weeks pregnancy was diagnosed with HIV on the routine blood investigation when she came first time for the checkup. So when we got the all investigations, HIV was positive. So here the important points are, questions are, how will you counsel this couple when patient is diagnosed recently with the early pregnancy? And enumerate 3 important maternal risk factors which would increase the risk of PTCT. Nowadays, we don't say MTCT, we say PTCT, parent to child transmission, okay? And third question is, how frequently would you like to do RNA copies and CD4 count during the pregnancy? So now we go to the answers. Mr. Vinod, next slide.
So what is the answer of first question, the counseling? What are the important points in the counseling? So we have to see the important points, because this patient has to be on the ART, and we have to explain this couple in detail about the importance of the ART and what is the effect of the ART on the child. And if she doesn't take, then what would be the effect and what will be the chances of the recurrent chances of the infection transfer to the baby. And if she takes, and then what will be the chances. So she has to understand, couple has to understand, then only the mother will be compliant to the ART. So we have to talk about the ART in detail and counsel them what is the importance, because suppose patient takes, then the chances are very, very less, only 1 to 2% of the infection chances to the baby. So she has to understand the importance of the ART. And a risk of the infection to the baby, as I said, we have to talk in detail with and without the ART. We have to discuss so that she has to understand and be compliant. And what is the role of the termination of pregnancy in this scenario? There is no role of the termination of pregnancy, because this is HIV positive is not an indication for termination of pregnancy. So we can counsel, there is hardly any infection rate, and she can continue. She has to understand the importance of ART. She has to be on the ART throughout the pregnancy, and she has to deliver at the tertiary care center under the specialized obstetrician, so that we can reduce the chances of infection to the fetus. And another important point is need of regular antenatal checkup, because she has to be very compliant and regular in her antenatal checkup, and she has to have the institutional delivery so that she can be looked after in a proper way. And need of the exclusive breastfeeding. From the very starting, she should be explained the importance of exclusive breastfeeding. What is the importance of the exclusive breastfeeding? And when she mix up, and when she has to be on the formula, baby has to be the formula feeding, what is the importance? What are the important points? So she has to be explained. So in the Indian scenario, we have to motivate the mother from the very beginning, from the starting of the pregnancy. That's what is the importance of the exclusive breastfeeding. Otherwise, also we have to explain the mother that they should breastfeed their baby exclusively for the 6 months at least, especially in this scenario when mother is on ART and HIV positive. She has to breastfeed her child for the 6 months exclusively, so that we should not increase the chances of infection to the baby. Now, next slide. So this was the answer of the first question. So answer of next question, what are the maternal factors would increase the PTCT? The important things are the high viral load, means mother is having the high viral load, there are higher chances of the infection to the baby. And when mother is having the advanced stage of the disease, then also there is higher chances of the infection to the fetus. And when there is a concurrent sexually transmitted other infections are there, they also increase the chances of PTCT. And maternal malnutrition is also an aggravating factor. So we have to correct the malnutrition of the mother. So we have to explain her about the nutrition, importance of the nutrition, and she should be encouraged to be on the good nutrition diet. And if there is a viral, bacterial, and parasitic placental infection, then also there are higher chances of PTCT. So these are the important points which we have to be paying attention and explain the mother, and we have to look after these points and give the proper treatment, whatever is required whenever we diagnose these things, and explain the mother, so then we can reduce the chances of PTCT. Now, coming to the another answer of the another question. Next slide. Next slide, Mr. Vinod. Yeah, so coming to the RNA copies and CD4 count. So how frequently we should do these things during the pregnancy? So whenever you are starting the ART, we should be knowing the baseline RNA copies and CD4 count. And whenever you are changing the ART, if there is a resistance development, or you have to change the ART because of the whether she has developed the resistance, or whether she is allergic to something, or there is an interaction of the drugs, then we have to change the ART. Then you have to do the repeat RNA copies and CD4 count. And in every trimester, otherwise also, if she's on continuous ART, then we have to do RNA copies and CD4 count in every trimester. When you are starting in the first trimester and in the second trimester and in the end of the third trimester also. And at the 36, 37 weeks also, again, we have to repeat, because according to the level of the RNA copies and CD4 count, we have to decide the mode of the delivery. If RNA copies are negligible and CD4 count is more than 300, then we can motivate the mother for the normal vaginal delivery. So now it's not necessary that all HIV patients should undergo the cesarean. No, if the RNA copies are negligible, they can be motivated for the vaginal delivery. And what precautions we will take, we will discuss in the coming few slides. So next slide. Now coming to the another scenario, here this patient is diagnosed HIV positive patient, second gravida with previous one baby, normal delivery, and she's on ART throughout the pregnancy. Now she has come in the early labor, and now on examination, she's 2 centimeter dilated, cervix is 60 to 70% effaced, vertex at -2, and membranes are present. So this is an important point, and her pelvis is adequate because she's second gravida and she had first normal delivery. So questions are, what is the NACO recommended ART? What precautions during labor? And what are the guidelines for the breastfeeding in low resource countries? As I already discussed about the breastfeeding, but now we will go to the answers of these questions. So next slide. Now, what is the recommended NACO ART regime? Because NACO recommends that any patient who's in the early pregnancy or any stage, whenever she comes to you and she's HIV positive, or she comes, her HIV comes positive during the pregnancy or even in the labor, you have to start the 3-drug regime. And otherwise, she should be on the lifelong ART whenever she comes to you. Okay, so first line ART, NACO recommended ART is 3-drug that includes tenofovir, lamivudine, and ifabinase. So this should be given throughout the pregnancy, during the labor, and during the breastfeeding also. Otherwise, also for her own health, she should be on the lifelong ART. So coming to the answer of the next question, next slide. Yeah, what precautions we should take during the labor? So important thing, we should avoid unnecessary vaginal examinations. We should avoid prolonged labor in these patients. So whenever there is any indication, we should just decide immediately and avoid the prolonged labor. We cannot keep waiting. So when you have to decide, because if the membranes are ruptured more than 4 hours, we should immediately take a decision for the cesarean. Or when the high viral load, then also immediately, whenever she comes in the early labor, and suppose this patient, she's coming in the early labor, membranes are intact. If her viral load is very high, then immediately she should be going for the cesarean so that we can avoid the infection to the fetus. And because otherwise the baby will be exposed to the vaginal discharges and the liquor, which is having the high viral load and viruses. So baby will be exposed unnecessarily to the infected vaginal discharges. So, and avoid the premature rupture of the membranes. Here, there is no role of the ARM. So we have to avoid, if it is indicated, then otherwise rather we should motivate the patient for the cesarean rather than doing the unnecessary ARM in early labor. If she's fully dilated, definitely you can do the membrane rupture and make a deliver within 1 or 2 hours. And she should be on continuous ART even throughout the labor. And then this should be continued in the postpartum period also. So now coming to the answer of the third question. Next slide. Now about the breastfeeding, WHO recommends that there should be exclusive breastfeeding with ART for at least 6 months, especially in the low resource countries, and our India is also low resource country. So we should motivate our patients if they are having the low viral load and the CD4 count is almost normal, more than 250, then they should be motivated to have the exclusive breastfeeding for 6 months. No mixed mixed feeding should be encouraged, and after 6 months they should stop the breastfeeding and they should be on the formula, or the cow milk can be given to the babies. Okay, so next, coming to the next scenario. Now here, patient is primary gravida with 35 weeks pregnancy with gestational hypertension, well controlled on 2 antihypertensive medicines. Ultrasound shows the AGA fetus with AVI is 10 and with CPR is more than 1. Water is just borderline, AVI is just borderline. Otherwise, she is well controlled on 2 antihypertensive medicines. So questions are, what is the incidence of PET in primary gravida and Paris women? And enumerate any 4 risk factors for preeclampsia and at what gestation this patient should be delivered. So now coming to the answers. Next slide. Now answer is in primary gravida, the incidence of PET is 2 to 7% and 1 to 5% in Paris women. And it's quite high in twin pregnancy, that is 14%. And even still it is very high in the patients who had the history of PET in the previous pregnancy. So we have to be very careful, especially in these patients. Now coming to the next answer of the next question. Next slide. Yeah, what are the risk factors? So these are the risk factors, most important: nulliparity, obesity, chronic hypertension, SLE, thrombophilia, history of the diabetes, kidney disease, and family history of the PET. So these are the important risk factors which increases the chances of PE in the patient. Now coming to the answer of the third question. Now next slide. Now this patient actually should be closely monitored for the progression of any severity of the disease, hypertension, or development of the PE, and or there is a development of the fetal growth restriction. Then accordingly you have to monitor this patient and decide and take a decision for the delivery of this patient. Otherwise, if she is well controlled and baby's growth is all right, Liker is all right, and CPR remains more than 1, then at 37 weeks, her cervix can be assessed. If it is favorable, then induction can be planned for this patient. Okay, so they should be taken up to 37 or plus 37, and then they should be planned for the delivery. Okay, coming to the next scenario. Next slide, Mr. Vinod. Yeah, so just have a look of these 2 pictures. I don't know whether you can make out anything. Dr. Elad, whether they can make out?
I think so, ma'am. They are answering.
Okay.
In the chat box, you can see the answers, ma'am.
Okay, yeah.
One of them has answered as Bartholin cyst.
Yeah, the another picture is, one is Bartholin cyst. Okay, what is another picture? Bartholin abscess.
They are giving Gartner duct.
Gartner is, no, site is not of the Gartner, not hematoma, because she's not the delivered patient. Okay, somebody is writing vulval hematoma. No, this is not vulval hematoma. Okay, so the A picture is the Bartholin cyst, very small and almost asymptomatic, but on examination, you just revealed there is a small Bartholin cyst. The another, because it's having the bluish surface and edematous, so this is a Bartholin abscess. Okay. Now coming to the next, what are the questions? Mr. Vinod, next slide. Yeah, the questions are identify the conditions. So we have identified what is the etiology and the treatment of these 2 conditions. So coming to the answers. Now what is the etiology? The etiology of Bartholin cyst, because Bartholin gland is a vestibular gland and lined by, next slide. And this gland is lined by transitional epithelium, and this gland is prone to obstruction, because if mouth is blocked, then there is an obstruction to the discharge and it will make the cyst. So blockage of the mouth of the gland, duct of the Bartholin gland will cause the Bartholin cyst. And if there is a secondary infection or superadded infection of this cyst, then it will become the abscess. So superinfection is usually microbial, and 10% of abscess may be caused by the gonorrhea. Next answer of the next question. So if there is a Bartholin cyst and very small, as such there is no symptom, then we can just wait and watch. As such, they don't need any treatment unless there is an infection or there is a big size. In the abscess, you have to do IND or marsupialization or resection of the gland. If there is a again recurrence multiple times, then you have to resect whole of the gland. Okay. So I think I completed my all the scenarios. Now I would like to invite Dr. Geeta for the further proceedings and further scenarios and discussion. Dr. Geeta, are you there?
Yeah, Dr. Chandra, can you hear me?
Dr. Geeta, I can't hear
Voice
you.
is slightly low, ma'am.
Yeah,
Increase
the volume.
अभी आवाज आ रही है मेरी?
better. It's better, but still you can increase your volume.
Okay, can you hear me now?
Yes,
Yeah,
ma'am.
better.
Okay, now I am the maximum. Actually, I'm in
Yeah.
the this area, maybe a little disturbance. So anyway, Ela, thank you very much for inviting me. And thank you, Dr. Mamta and Dr. Chandra. Can we have the
Geeta.
first?
Next slide, Mr. Bino. Yeah.
Yeah. So now, as students, as Dr. Chandra and Dr. Mamta have already very nicely elaborated to you, you will be in the OSCE given questions, which may be in the form of visual pics or some case scenarios or a OT post-operation scenario, and asked questions. Usually they are, varying between 6 marks to 8 marks, and the examiner, when they examine, we are given a checklist. So if you answer all that to the point, you get full marks. So OSCE is a chance for you to get full marks provided you answer the questions to the point. So now please look at this picture, and I'm going to ask you three questions. Now this is a female aged 35 years, para 2, L2, attended the gynae OPD with bleeding per vaginum off and on since 1 month with blood stained discharge. Now, systemic and abdominal examinations were normal, and per speculum is shown in the picture. Please tell 2 differential diagnoses. That's question number 1. And you may be, this will be probably having 2 marks. Then enlist 2 investigations which you will advise, and how will you treat this condition. So this will be a 6-mark question giving 2 marks each. So now coming to the answers. Now this differential diagnosis you were asked, any 2 differentials. So next slide, please. So this could be a cervical polyp. Next slide, please. So this could be a cervical polyp, as many of you have answered. This could be an endometrial polyp or a fibroid polyp, or it could be a placental polyp or an inversion of the uterus. So if you can write any of these 2 of these answers, and the ultrasound and pelvis will give you the answer in most of the cases. And the second investigation, which you would write in your answer is a pap smear, LBC, liquid based cytology, and an HPV. And the third question, which you said, how will you treat this condition? Well, you would perform a colposcopy with a via villi, and also do a hysteroscopic guided procedure if it is an endometrial polyp or a fibroid polyp or a malignant polyp, as the case may be, but you would do a polypectomy, hysteroscopic guided. Question 2, next slide. Now, this is, as you can see, visual inspection after Lugol's iodine. Ela, can you see this picture now?
Yes, ma'am.
Yeah, so there can be 3 questions that can be asked to the students. First will be, describe the picture. Second question is, what solution is used for this test and how is it prepared? And third question, what is the change in precancerous and cancerous lesion and how is it caused? So you can get a 6-mark question for this. So coming to how you will answer to the point, please note how we are giving you very to the point answers. So describe the picture, you will say this is a villi. Next slide, Vinod. So this is a visual inspection with Lugol's iodine, showing scattered iodine negative areas on anterior and posterior lip. This is the answer to the first question that you have to describe. So it is a villi and there is a iodine negative areas. Then the question was, what solution is used and how is it prepared? So this is Lugol's iodine. Basically, Lugol's iodine is nothing but 5% iodine and 10% potassium iodide. You can remember it as 5-10, double. 5 iodine, 10 potassium iodide. And the other part is, how do you prepare? So you dissolve potassium iodide in about 20-30 ml of distilled water. Add iodine and heat gently with constant mixing until iodine is dissolved. And then when this is prepared, you can dilute 100 ml with distilled water and store. It is very important. In your OT, you must have seen this is an amber glass stopper. You never use a cork. You always use a glass stopper for these solution. It is amber colored bottle. Now, the third question we were asked is, what is the change in precancerous and cancerous? So in villi, the normal squamous epithelium we know contains glycogen, and iodine being glycophilic, it is taken up by the squamous epithelium, making it mahogany brown, mahogany black. Columnar cells, this is endocervical cells, do not take, you must have seen when you do villi, there is no endocervical columnar epithelium stain because it doesn't change in color because it doesn't have glycogen. Now, how the difference is in the cancerous and precancerous, the immature metaplasia and inflammatory lesions are only partially glycogenic. We all know that this is all Vasundhara. Immature metaplasia and inflammatory lesions are only partially glycogenated, and when stained, they appear as scattered, ill-defined uptake area. Whereas the immature and the cancerous lesions do not take up iodine as they lack glycogen, and they appear as mustard, or you can say canary yellow or saffron yellow areas. So this will be probably a 6 to 7 mark question. Next, please. Now, next question is that patient presents with a thin white discharge, very common complaint in the OPD. She says she has no itching, but discharge is copious. So there's a very important history, no itching, but copious. So the two questions you can be asked is, what are the Amsel's criteria for diagnosis of bacterial vaginosis? And describe the differentiating clinical features between candidal discharge and trichomonas discharge. So how you will answer now this question, this will be maybe 2 marks for Amsel's and 4 marks for this second question. So in 2 marks, you have to just say Amsel's criteria. There are 4 criteria, half mark each. So you will get 2 marks if you answer. And all of you are writing Amsel's criteria. Okay, so we give you the answer. The next slide, that basically there is a fishy odor when you add alkali, that is 10% potassium hydroxide. Usually the discharge is very thin, white, homogeneous. And once you add KOH, it gives you a very fishy odor. Then when you put it in the microscope in a hanging drop preparation, you in a gram stain, you get clue cells. Why they are called clue cells? Because they give you clue to the diagnosis of bacterial vaginosis. The vaginal squamous cells have got these little bacteroids stuck to the periphery of the cells. So they are giving you clue. And fourth criteria is the pH of the vaginal fluid, which is normally acidic. It becomes more than 4.5. So the other question was, how will you differentiate it? Now, trichomonas is a usually sexually transmitted disease. On microscopic, you can see the flagellate protozoan having exostyle and cystostome, and there's an elongated nucleus. Clinically, it's a typically frothy. You will see the jhag. Actually, you will see jhag. If you're alert in your OPDs, you must have seen this frothy green discharge and very mild itching. As I said, in bacterial vaginosis, there is hardly any itching. Whereas in candidiasis, there is a lot of itching. It is not a STD, and pseudo-hyphae, budding yeast cells are seen. And clinically, you see this curdy white discharge or cheesy white discharge, which is coating the cervix and vagina, with punctate hemorrhages seen after removing the discharge. Next slide, please. Okay, so now this is one of my favorite questions. You will be given this kind of a diagram, and based on this diagram, various questions may be asked. I hope you can see this, the levels, level 1, level 2, level 3.
Yes, ma'am.
Okay, so the questions which you are usually asked pertaining to this is that after whom are these levels of support named? So this will probably be just a half a mark or 1 mark question. And the second question will be, describe the components of these 3 levels of support. So again, this can be a 4 mark question, 1 mark for first and 3 marks for the second. So how you will answer? Very to the point. You will simply say Delancey. Next slide. And then the 3 levels, very clinically Crisp answer, level 1, cardinal uterosacral ligaments. Level 2 is your vesicovaginal fascia, rectovaginal fascia, which is in turn attached to the arcus tendineus fascia pelvis, which is also attached to the uterosacral ligaments. And third level of Delancey is the perineal body, which is in turn attached to the rectovaginal fascia. So it's a very clear-cut, crisp answer. You don't have to describe what will happen if level 1 defect occurs. You will have a nulliparous prolapse. We have not asked you. We have asked the components. So please read question carefully and answer to the point. Next slide, please. Okay, so this, as you can see, is an ultrasound picture, and you can see the spine, the tram track appearance, and suddenly the arrow is showing you a deficient point. Can you see that? So if you can see, this is not a nuchal translucency. Somebody has answered nuchal. This is not a nuchal translucency. This is a spinal cord axial sections which are taking place. A picture is of that one. So next slide. The question you can be asked is, the above condition is most common in which part of the spine? Number 1. What are the commonest cranial ultrasound signs of this condition in the second trimester ultrasound? Third question can be, which serum marker in the quadruple screen test would be increased in this condition? And what abnormalities or conditions are associated? Once you see this, what will be the associated one? So one correct answer I am getting. Very good. So the answer, how you will answer this is that the question was which part of the spine. So this is commonest is lumbosacral spine. This meningomyelocele is there. There is a deficiency there, and there is a meninges are protruding. So this is a meningo, and if the no spinal cord, it's only meninges, then meningocele. Otherwise, if it is both, then meningomyelocele. Most commonly in lumbosacral spine, almost 65%. And the second question is, what are the commonest cranial ultrasound? So if you see this, immediately you should put your transducer on the cranial and see it is associated with the banana sign and the lemon sign, which is the open spina bifida. If it is there, it is associated with the Arnold-Chiari type 2 malformation. And because of this Arnold-Chiari malformation, there is a caudal displacement of the brain and obliteration of the cisterna magna. That is why you get the typical lemon sign and the banana sign. And in the second trimester, there is a frontal bone scalloping, which is the lemon sign, and obliteration of the cisterna, as I told you, which gives you a banana sign. Now the question was serum marker. You have all answered correctly. It is maternal serum alpha protoprotein, which will be more than 2.5 moms. Other question is, what abnormalities, if you see this, what are the other things you will look for? So this can be raised maternal serum alpha protoprotein can be associated with majorly neural tube defects, but also anterior abdominal wall defects, congenital nephrosis, and wrong dates. You must always correct your dates. Then multiple gestation and placental problems like IUGR, IUD, abruption, preeclampsia. And other things it can be associated with this folic acid deficiency, and you must take the family history of previous neural tube defects in this patient, or nutritional deficiency majorly. Most of the neural tubes you see in your general OPDs are nutritional deficiency caused by folic acid deficiency. Then some chromosomal problems like trisomy 18, then single gene defects, maternal diabetes, use of anti-epileptics are also implicated in roughly 10% cases. And what are the implication abnormalities you get in these babies? They get bladder bowel incontinence, weakness, paralysis of lower limbs, and hydrocephalus. And if you notice in the yesterday's paper, there was this court has given permission to terminate a baby with spina bifida, I think at 30 weeks gestation. Vasundhara, please. At 30 weeks gestation, they have given, the court has given permission to, because of this bladder bowel incontinence and paralysis danger. Next slide, please. Another ultrasound showing, now this is the cranial parts. I think somebody had answered NT in the previous one. This is the cranial ultrasound. As you can see the plus sign, which is measuring the nuchal translucency. So the question which you will be asked, usually are asked in this kind of a scenario is, what is the optimal gestational age and the CRL for performing the NT scan? What should be included in an, if you are doing an NT scan as an ultrasonologist, what all you should see? What happens to beta HCG and Pepe markers in trisomy 18, 13, and 21? And what are the implications and associations of an increased NT? So I have given you 4-5 questions. You can be asked any of these 2-3 out of these when you get this kind of a picture. So the optimal gestational age, as we all know, have you, somebody, if you are written also, it's 11 weeks to 13 plus 6 weeks of gestation. And this is corresponding to a CRL of 45 to 84 millimeter. Next slide, please. So 40 to 84 millimeter is CRL, which you should do it. Now, second question is, what is the detailed history? The slide, next slide, please. So the detailed history, and what you should see is, you should give a detailed history when you write a prescription for NT scan, and the ultrasonologist will look for NT, CRL, BPD, FLAC. He will look for nasal bone, ductus venosus assessment. He will rule out tricuspid regurgitation. Uterine artery PI mean will be calculated, fetal heart rate, cervix, placenta, and amniotic fluid. And in case of twin, it is chorionicity which should be mentioned. And also it should actually be NT and early anomaly scan for diagnosis of fetal defects. The next question we asked is, what happens to beta HCG and Pepe? As you can see in trisomy 21, beta HCG is 2 moms or above and Pepe is very low. Whereas in 13, 18, both are low. So this is important. You can just read the thing yourself and you can see, excepting 13, 18, 20. Now, what are the implications, associations of the increased NT? Chromosomal anomalies, you know, prevalence increases with NT. 0.2% if NT is less than 95th centile. It can, if it is more than 6.5 mm, then chance of chromosomal anomalies can be 65%. Then high NT associated with fetal death, major defects, severe genetic syndromes like achondrogenesis, achondroplasia, Noonan, DiGeorge's, akinesia, frame, rectal abnormalities. So there are a lot of problems associated whenever you have a raised NT. Next slide, please. Now, this is an ultrasound picture of a patient presenting at second gravida, para 1, no abortion, with 5 weeks of amenorrhea with pain abdomen. And as you can see, ring of fire in the left adnexa, there is a left ectopic. Very good. So that's a correct diagnosis made by all of you. So that is a left ectopic pain. And as you can see, there is no free fluid, but there's a tiny equiluscent area with a ring of fire. So next slide. Questions which you will be asked over this is, when we should consider methotrexate? That means you have to mention the criteria. How do you monitor or follow up patient on methotrexate? What drugs are to be avoided when patient is on methotrexate? And how long to avoid pregnancy after methotrexate? And what surgery is done for ectopic pregnancy? So next slide. So let's go one by one. If you were to ask, I mean, I'm giving you all the questions which you may be asked. So one or two they will be asking. So criteria are very clear. These are from the RCOG guidelines, that when patient is clinically stable, that's the most important criteria. Second, beta HCG 1500 to 5000. Very easy to remember. Clinically stable, 15 to 5, no fetal heart, gestational sac less than 35, no intrauterine pregnancy, and patient should be willing for follow-up and not going to the village after this. And she should not be allergic to methotrexate. So these are the few criteria which you must fulfill: 15 to 5000, stable patient, no fetal heart rate, sacs less than 35 mm. Then beta HCG, how do you monitor? You will monitor the beta HCG on day 4 and day 7 after methotrexate. And if and only if it falls to more than 15%, then you consider the expectant management as safe. And then thereafter, you do weekly beta HCG till it is less than 10. However, if it doesn't fall, you discontinue methotrexate. Then the question I asked was what drugs to be avoided. It is very important that alcohol to be avoided and folic acid is to be avoided. And the last question was how long to avoid pregnancy. It is said 3 months after the last dose because it's teratogenic. So 3 months after the last dose. Now what surgery? You can do a salpingostomy if the contralateral tube is also abnormal. I mean, try to do an ostomy if it is abnormal. But if it is normal, then you can do an ostomy. But if salpingectomy, if the contralateral tube is looking normal, you can do salpingectomy also. Next slide, please. So now, in the next question is carbetocin. Now, folic acid you have to avoid in methotrexate because these are all folic acid antagonists. Methotrexate is a folic acid antagonist. That is how it acts as an anti-cancer drug. So if you give folic acid, you are reversing its effect, right? So carbetocin. Now, this is very famous question. You will all be definitely asked either table viva or OSCE. So this will be shown to you, 100 microgram per ml, and they will be shown the ampoule. And they will ask any questions. Now, next slide. These are the various questions, dear students, you can be asked. So I will answer one by one. So what is carbetocin? What is the difference between half-life? How it works? What are the contraindications? Has WHO recommended carbetocin for prevention of PPH? And what is the dose? Can it be diluted? And when should it be given? So you can be asked anything of these 6 scenarios or things relevant to the carbetocin. So I will give one by one answer. So next slide. Carbetocin is a synthetic analog of human oxytocin with some structural modifications. You don't have to know all this, but if you go closely, you want to have distinction viva, left side on the carbetocin, you can see an extra OH line which is marked, and in the oxytocin that is missing. That is what prolongs the pharmacologic effect of the carbetocin and makes it long acting. Next slide. Now coming to the half-life problem. Half-life for carbetocin is 40 minutes and oxytocin is 4 minutes. So it is 10 minutes, 10-fold higher. Duration of action of carbetocin is also longer than whether IV or IM oxytocin. And it was found that a single IV bolus injection of carbetocin was at least as effective as 16 hours of continuous oxytocin infusion. And most important, carbetocin needed no repeated administration in various studies, and also no dose variation or single dose carbetocin is found to be effective in controlling PPH, unlike oxytocin. You have a single dose. You don't have to increase it to 40 units or 60 units. If you give carbetocin, it will control your PPH. That's single 100 microgram per ml dose. Next slide. So it is superior over oxytocin. Next slide. So oxytocin is short acting and it is used majorly for inducing, augmenting labor. Men may desensitize the oxytocin receptors, thereby impairing oxytocin's post-delivery effects on the uterine contractility. So it is short acting and duration, as I said, is just 15 to 20 minutes. And it has to be given as a continuous IV infusion to attain that. That is why if you give carbetocin, you give one dose because 40 minutes it will act. This will go away in 4 minutes. Next slide. Next slide. Next slide. So what are the contraindications? Majorly epilepsy, because before delivery, it may cause respiratory or cardiac distress in mother or baby. And it is not contraindicated, I will say, but relatively contraindication used with caution in hypertensive patients. Excuse me. Next slide. And regarding the question about WHO, as you can see very clearly, WHO has recommended it as a part of effective uterotonic. It is way back in 2018 guidelines. It is very clear that it is recommended as an active management of third stage of labor. Next slide, please. Right. Next slide. Next slide. So it is a 100 microgram per ml. It is a solution for injection and indicated in the, mind you, prevention of uterine atony and excessive bleeding following delivery of the infant, PPH by cesarean or vaginal delivery. And when the question, when it should be given, it is administered after delivery of the infant, mind you. You are not supposed to give carbetocin before. You have to give carbetocin after delivery. The anesthetist must be told to give this thing after the delivery of the infant. And majorly, we are propagating it for prevention of PPH, mind you, at the moment. However, some studies have been done where they have used it for treatment, but it is not so effective in treatment as it is in prevention. So this also PG students must understand prevention of PPH and delivery of the infant after delivery of the infant. Next slide. So in cesarean section, single dose 1 ml should be administered intravenously as a bolus injection slowly over 1 minute after delivery of infant. And if you are doing a vaginal delivery, you should administer after delivery of the infant over 1 minute bolus for active management. Right, over 1 minute. Thank you. Do we have any more questions? I'm sorry. I think we are done.
I think all the questions have been answered. Yeah.
Asha, okay, one last question. Pap smear, small pap smear. Now, can you see this arrow? This is very commonly asked. Ila, I think all PGs should know how to read a pap smear. Next slide. So the question will be identify and describe the image at A and give the diagnosis. Do you need to confirm the diagnosis? What is the recommended screening protocol for cervical cancer by pap smear? I mentioned 3 points and name 2 other methods that can be used for screening of cervical cancer on OPD basis. These are very simple questions, and quickly I will tell you that these are malignant squamous cells, and how you can recognize, describe is that they are increased. Can you go back to the slide, the photograph? Can you see the increased nuclear cytoplasmic ratio, the coarse chromatin and isocytosis? This is cervical cancer. Second question you were asked was, do you need to confirm? Definitely. Definitely. Just on basis of pap smear, you don't say she has CA cervix, you have to confirm. Then the screening protocol, you all must know that at 21 years of age, you can start in sexually active women. But FOXI guideline says 24 years. So you just can say that in bracket that yes, 24 years as per FOXI, otherwise 21. Every 3 years, if you are doing only LBC, but if you are post-testing with HPV, then every 5 years, and you finish it at age 65 years. And other methods, if you are in a low resource, it is via and Willy. Thank you, Ila. Thank you so much. I am done. Thank you.
Dr. Geeta, are you there? Geeta ma'am, are you there?
Yeah, yes, Ila.
Yeah, ma'am, there is one question pertaining to carbetocin. One of the students have asked that can carbetocin can be given to eclampsia patients?
Yeah, it is, as I said, it is a relative contraindication in hypertensive patients. You can use it with caution. And please remember, carbetocin is to be used in active management of 3rd stage. That is, patient is just delivering normally or on a cesarean with hypertension. Just as you avoid methogen, it is better to be careful while using. Absolute contraindication they have noted is epilepsy.
And is carbetocin available in government setup?
Yes, I believe so. I think last time I was talking and I was hearing in a webinar of DGF, Dr. Sharda Jain was making a lot of efforts to make it available. But I think it should be shortly available. I am sure it must be available by now.
Not yet, not yet.
Not yet? Okay. But I was hearing in that webinar that they are making a lot of efforts with the health ministry, because it's a real wonder drug. And from personal experience in Gangaram, I can tell all the PG students that it is a wonder drug, provided you use it at the active management of 3rd stage, not for treatment of PPH. Again, I am repeating, because the WHO criteria are very, very clear. that the recommendation has in fact it has replaced carboprost. It has replaced carboprost for the prevention of PPH.
And ma'am, one more question. Can carbetocin and oxytocin be given together?
Thank you, Dr. Leela. Thank you for being there.
Yeah, I think, ma'am, there was one more question. Can you take it?
Yes, please.
Yeah, can carbetocin and oxytocin be given together?
Yeah, very good question. So there were a lot of studies have been done, and they found that in 80% of women who were given carbetocin for AMTSL, please listen to each every word I'm speaking. 80% of women who received carbetocin for AMTSL did not require additional uterotonics. 20% required additional uterotonics. Number one. Number two, the need for blood transfusion less. Hemoglobin fall less. Twins in twins and previous cesareans also less hemoglobin fall, less need for blood transfusion. So you are right, 80% no more, 20% yes, they required.
Okay, ma'am, I think with this we end the session. Thank you so much, Dr. Geeta.
Thank you, Ela.
Thank you, Dr. Chandra and Dr. Mamta. Now we start with our next session, which is again a case presentation by Dr. Jyotsna Mishra. Dr. Jyotsna, are you there? I would like to invite my moderators, Dr. Manju Puri, who is Director Professor in the Department of Obstetrics and Gynae at Lady Hardinge Medical College, New Delhi. Ma'am is actually stuck somewhere in an emergency. She'll shortly join us. Then Dr. Sheila Mane. Yeah, she is currently DNB faculty at KCG Hospital, Bengaluru. She is the ICOG Governing Council member, President of Isopap Society, Bengaluru, and President Bengaluru Menopause Society. A very good afternoon to you, ma'am.
Thank you.
Dr. Pratima Mittal, who is a professor and consultant in the Department of Obstetrics and Gynae at VMMC and Safdarjung Hospital, New Delhi. A very good afternoon to you, ma'am. And Dr. Sakshi Nair, who is associate consultant in the Institute of Obstetrics and Gynecology, Sir Gangaram Hospital. Hi, Sakshi. Hello. So we start with the case presentation by Dr. Jyotsna. Dr. Jyotsna, over to you. I think she's not able to join. Mr. Vinod, is Dr. Jyotsna there? Mr. Vinod?
No, ma'am, she's not here. I'm just trying to calling her.
Hello, Dr. Sakshi. Hello, Dr. Pratima. Hello,
Hi,
Dr.
ma'am.
Leela.
Yeah, good afternoon, ma'am.
Good afternoon. Unmute yourself.
You are mute.
Hello. 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 Nice to see you, Sheila.
Yeah.
And it's really nice to be there in Gurukul classes. You know, it reminds me such gives a very nice feeling, you know, because all the people, senior people are there. Yesterday, I saw Dr. Kotwani. I was really, you know, went into the old age of mine, you know, when I was a postgraduate. And Sakshi is conducting the program so well. Congratulations, Sakshi. So now, you know, now we will hand over the baton to you, you know, now you conduct the case. We will just give our inputs. In between.
I think that is better.
No,
Yeah.
ma'am, you are required.
No, we are all there.
We are there. We are there.
Yeah.
Ma'am, absolutely, you guys have to be there because she is she is in my unit only.
Okay, so that's better, you know.
So I gave her my input already. I told her this question, so that is why I want you guys to ask the questions.
You start, and then we will add.
You started. Where is she now? Not yet joined.
Has she joined?
I just called her up. She said, I'm joining.
I think that will take another minute or so.
I called her. She said, I'm joining.
this DNB candidates are there in Gangaram now?
Ma'am, currently actually the new ones have not joined so far. So new ones with the we have got 2 secondary DNPs only as of now, the ones who've done DGO. And बाकी pre-existing हमारे पास 4 हैं.
Okay.
आपके पास भी अभी डीजीओ दिया हुआ है? डीजीओ शुरू हो रहा है?
नहीं हमारे
नहीं
हमारे यहाँ पे है, हमारे यहाँ पे एनबी का डीजीओ है.
अच्छा नहीं हमारे यहाँ पे DGO नहीं है.
And 2 candidates have joined for DGO. We have got 2 secondaries. Primaries will take some time. So
how many PGs are there attending this course now? How many registered?
122.
122 participants are there.
Okay.
A good number.
Good number. So ask her क्या हुआ? उसके बिना तो चलेगा नहीं ना.
I'll just call her up again. I'll just see why she's not here.
Even I just called her up.
कितना नो तो.
She has joined now. I think her slides are being shown. Dr. Jyotsna, are you here? Dr. Jyotsna?
She's not able to join from her console, so I'm going to hand over my console to her. All right.
Okay, no problem.
Yeah, come. Sit.
Good evening, ma'am.
Just relax yourself, Dr. Jyotsna. Don't worry. Start.
I'll be presenting a case on anemia and pregnancy. My patient is Mrs. X, 30 years old with 8 months of amenorrhea. She was booked with us, educated up to 12th standard. She is housewife, belonging to socioeconomic class 4, resident of Pitampura, New Delhi. She came to us with complaints of mild fatigue and generalized weakness from past 1 month. Her husband is Mrs. Y, who is educated up to 12th standard and working as a tailor. History of presenting illness. Patient was admitted with us to us with complaints of easy fatigability for past 1 month and generalized weakness and tiredness from past 1 month. There is no history of breathlessness, palpitations, chest pain, orthopnea, or paroxysmal nocturnal dyspnea. There is no history of swelling of legs. There is no history of discoloration of skin or eye. There is no history of urinary complaints. No history of chronic cough. No history of ulcers over the mouth. There is no history of hematemesis, any recurrent diarrhea or blood in stools. No history of barefoot walking. No history of passage of worms in stools. No history of cravings for non-nutritional things like sand. No history of blood transfusion. No history of passage of worms in stools. She perceives good fetal movements and there is no complaints of pain, abdomen, bleeding per vagina or leaking per vagina. Her trimester history. First trimester, it was a spontaneous conception. Her pregnancy was confirmed by urine pregnancy test at 45 days of amenorrhea. And she gives history that she started to take folic acid tablets at 1.5 months, but was not regular with those tablets. Early pregnancy scan as told by the patient was normal. Blood test done in the first trimester as told by her was normal. There is no history of fever with rashes, any urinary tract infection, radiation exposure, or spotting per vagina. In the second trimester, quickening was felt at 5th month of amenorrhea. 2 doses of tetanus toxide were taken at 5th and 7th month. She gives history that she was not able to take iron and calcium tablets regularly because of vomiting, recurrent vomiting, constipation, and epigastric pain. 5th month ultrasound.
Okay, suppose if a patient has given you the history that she was not able to take the iron and calcium tablets regularly.
Yes, ma'am.
Patient gives history of vomiting, constipation, and epigastric pain. So what further you would like to ask her if she gives this history? Anything like, yes, she has to take a tablet at a particular time. So is that?
Yes, ma'am. I will ask her what time, how she was consuming the tablet. Because most probably iron tablets when taken on an empty stomach, they can cause nausea and vomiting.
Okay, that is one thing. So ideally, when somebody has to take an iron tablet, what is your advice?
Whenever my patient comes to me, I will explain her properly that the best time to take iron tablet is ideally before meals, but because it causes nausea and vomiting, it should be taken at least 1 hour after meal. And any liquid preparation of iron, if she's taking, then it should be placed at the back of the mouth, because liquid iron preparation causes staining of teeth. And tablets should be taken along with some amla or nibu pani, because it increases the iron absorption from those tablets. And iron tablets should not be taken along with the calcium tablets, and at least 2 hours of gap should be there between the iron and calcium tablets.
Yeah, okay, fine, proceed.
5th month ultrasound, as told by the patient, was normal. There is no history suggestive of increased BP or diabetes, increased sugars. There is no history of bleeding per vagina. 3rd trimester, she perceives good fetal movements, and she came to us with complaints of generalized weakness and tiredness and easy fatigability last 1 month. On further history taking, I found out that she told that her hemoglobin was low during the CBC, hence she was admitted for further management. Menstrual history, she attained menarche at 13.
Was she admitted or she was just seen?
Admitted.
Ma'am, admitted.
Okay.
So if she is admitted, again, what significance it is? You said she is in 3rd trimester, history of amenorrhea of 8 months.
Yes, ma'am.
So she has anemia. She told her hemoglobin was low.
Yes, ma'am.
So she may be around some 34 weeks or something like that. So which patient you think will require admission?
Yes, ma'am.
Which patients will require admission?
Patients, if she comes at 34 weeks, because she's already crossed 34 weeks. So in my mind, I would like her to transfuse with IV iron. So
No. Which patients you will admit? I'm asking you. What category of patients? See, we see so many anemic patients in OPD.
I'm moderate to severe anemic patients.
Moderate to severe anemia. What do you mean by moderate means?
Ma'am, moderate anemia means, according to WHO, hemoglobin should be between 7 to 9.9 grams per deciliter, and severe is less than 7, and very severe is less than 4 grams per deciliter.
Very severe. So moderate anemia, if you are admitting at 34 weeks, what is your purpose of admitting her?
At 34 weeks, I cannot treat her with oral iron. I want to admit her for injectable iron.
So do you think for injectable iron, we have to admit her, or we can give it on a...
I want to, ma'am, further evaluate what is the cause of anemia of like for moderate anemia.
Okay.
Because IV iron can also be given on a day, by patient can be admitted in the morning and discharged by evening.
Okay, go ahead. Tell us more about this thing, her dietary habits and all.
Yes,
ma'am.
They have to control.
She's a primary gravida.
Yeah, so go ahead.
Primary gravida, ma'am. भैया ये नीचे नहीं जा रहा है. Ma'am, she consumes a vegetarian diet. At 8 a.m. she consumes 2 biscuits, tea and coffee. So ma'am, total calorie intake was 1,360 calories. And she is a sedentary worker, so the calorie deficit is around 525 calories.
And proteins? You have to calculate protein also, na?
Yes, ma'am.
आजकल तो easy हो गया आप लोगों के लिए. There are so many apps coming, you know, you can just put it in the app.
That is how beautifully she has calculated, I think.
Yes.
Yeah.
So you have to calculate. I think her protein should be okay. She is having milk in the evening, 3.3 here. And then she doesn't, dal also she is having.
But so, milk, I think milk quantity is comparatively less. Because
Yes,
if we look at protein.
So you should calculate protein intake also, right?
Yes,
okay.
Yes, past history, there is no history of any chronic renal diseases, worm infestations, hemorrhoids, any bleeding manifestations, history of recurrent urinary infections, blood transfusions. No history of diabetes, hypertension, tuberculosis, asthma, epilepsy, thyroid, or cardiac disorders. There is no history of previous surgeries. Personally, she has a normal sleep, normal bowel and bladder habits. She consumes vegetarian diet. There is no history of betel nut chewing or any addictions. She has access to modern toilet facility with adequate sanitation, and she wears chappals outside.
Okay. Jyotsna, can you summarize your case? I mean, we don't want to go in so much of
Yes,
detail.
ma'am. My patient, she's a 30-year-old book patient, Mrs. X, primary gravid at 34 weeks of gestation. From socioeconomic, she came to us with complaints of fatigue, general weakness, and tiredness from past 1 month. She with non-compliance to oral iron on a vegetarian diet, and carrying a single live intrauterine gestation and cephalic presentation, probably anemia complicating pregnancy, not in failure. Now admitted for further management.
So why do you say probably anemia? You said probably anemia. So what investigations will you do to confirm that it is anemia or nothing else? What differential diagnosis also you will tell me in this, and about the diagnosis of.
Because she tells that she's having fatigue, generalized weakness, breathlessness, tiredness. So it can be a cardiac disease also. But anemia is the most common cause of breathlessness in our country. So first, I would like to give a differential diagnosis will be anemia. Then I would like to investigate her by doing a CBC with all the indices like MCV, MCH, MCHC, peripheral smear, stool for occult blood and ovine parasites, urine examination, LFT, RFT, HPLC.
Why will you do HPLC for all the patients? Since she's a primary gravida, I mean, that's fine. There was no, did you ask the history of thalassemia? You never said something about.
I asked ma'am, any history of bleeding disorders in the family or any recurrent.
So, investigations, you said you will be asking her, HPLC, but what is the ideal timing? You know, you have still not diagnosed what type of anemia it is, right?
Yes, ma'am.
Yeah, even if it, suppose if it comes out as iron deficiency anemia, and you said that your patient must be having moderate to severe because she was advised admission, right? So before you try to rule out thalassemia, what is the prerequisite? If it is iron deficiency anemia, before you do the test, electrophoresis, HB electrophoresis, what is the prerequisite? Do you need to correct iron deficiency anemia before you advise this investigation?
Yes, ma'am.
Yeah, okay. Because
Yes,
due to iron deficiency anemia, it can still remain low, okay, and you may not get the correct diagnosis.
Yes, ma'am.
So you have to first treat the iron deficiency anemia and then ask. And as madam said, family history suggestive of that. And even if it is there, first you will correct the iron deficiency anemia and then you ask. Anything else in the investigation? Dr. Pratima, should we ask her? She said about indices. In indices, anything particular, because you said you would like to investigate her for thalassemia. Any particular indices which will help you to differentiate it from thalassemia?
Ma'am, red cell distribution width.
Yes. What happens to that in iron?
It will be elevated in cases of iron deficiency anemia, and it will be normal in cases of thalassemia.
Yeah.
Will it be elevated?
Anything else when you look at the hematocrit? Hematocrit. Will it change so much in thalassemia?
No, ma'am.
Madam, you have to unmute. Dr. Pratima, aap unmute kijiye.
So you have to see na, that what is the hematocrit, what is the PCV, all those indices you have to see.
Yes, ma'am.
So what
see, usually iron deficiency anemia, it is 1/3. Hemoglobin is 1/3 of hematocrit, but it may not be there with thalassemia. Okay, iron
Yes,
deficiency, it will be 1/3. Okay,
Yes,
suppose
ma'am.
if the hemoglobin is 7, you will get hematocrit as 21.
Yes,
if it is only iron deficiency.
Yes,
okay, and
okay, so what was the report in your case?
Ma'am, her hemoglobin was 8.4 grams per deciliter.
8.4.
Yes, ma'am.
What else? Other in investigations?
Other indices?
Ma'am, MCV was MCV, MCH, MCV, MCH, MCHC.
You have got a slide for that?
I don't have a slide, ma'am, for my investigation.
Okay. So tell us, what was your findings?
Ma'am, MCV, MCH, MCHC was low. Peripheral smear showed microcytic hypochromic anemia.
No anisocytosis, no poikilocytosis.
No anisocytosis, no poikilocytosis.
And what about reticulocyte count? Was there any abnormal cells? You have to describe a peripheral smear, in detail.
Madam is asking you whether there were any abnormal cells in peripheral smear.
No, ma'am.
Reticulocyte count.
No. Retic count was
What do you expect there? Is any abnormality which will help you to diagnose again thalassemia?
Ma'am, in thalassemia, we will have target cells,
You
hypersegmentation.
can get target cells. Yeah, target cells you can get, in peripheral smear.
Yes.
Okay. And again, RBC count is not low again.
What is target cell? How does it look like?
Ma'am, target cell consists of a central mass of hemoglobin surrounded by a ring of pallor with again a ring of hemoglobin. So it looks like the target, like the dot in the target. So that is why the name target cell.
Okay. So what else will you do? Now you have got a peripheral smear, which is suggestive of iron deficiency anemia, which is suggestive of your, nutritional deficiency anemia. What else, what other investigations would you like to do?
Ma'am, serum ferritin, TIBC, total iron binding capacity, serum iron, and transferrin saturation.
So what are the values you expect for serum ferritin?
Serum ferritin will be low, ma'am, should be low.
How much?
Value is around 60 to 120. It should, in iron deficiency anemia cases, ideally it will be less than 30 milligrams per deciliter. Then total iron capacity will be increased. Normal value is from 360 to 400. Here it will be more than 400 in iron deficiency anemia. And serum transferrin saturation normal is 200 to 360. It will be high here. Transferrin saturation will be high, and serum iron also will be low.
And suppose you see some fragmented cells on the, in the peripheral smear, then what will you think of?
It is suggestive of, ma'am, megaloblastic anemia and folic acid deficiency anemia.
So can it be, mixed type of picture?
Yes, ma'am, it can be, because in our diet is deficient. Our diet is in India, most common anemias are mixed anemia, nutritional anemias, which can be both because of iron deficiency anemia, folic acid, and vitamin B12 deficiencies.
Okay. So now you have done the investigations. What other investigations would you like to do when you have done your basic investigations and identified it as iron deficiency anemia? Would you like to rule out any other causes of leading to this chronic infections or something? Hello?
Yes, ma'am.
So kuch karoge? Will you do some other tests? One is nutrition is the cause, but other causes?
What are the other causes apart from thalassemia or hemoglobinopathies, the other conditions which can lead to anemia?
Ma'am, it can be a chronic disease, but she does not give any history of chronic diseases.
Yeah, but which are those?
Like tuberculosis. Any history of renal disorders, liver disorders.
Any infection anywhere,
any infection.
urinary tract infection also, you should do a urine routine microscopic and culture. And what about hookworm? What is this hookworm cycle like? Can you tell us why the patients, very common in our country?
Ma'am, hookworm also, there are two types of hookworm in India, that is Ankylostoma duodenale and Necator americanus, and it is most common in India because of barefoot walking. And the hookworm larva penetrates when the patient walks on the barefoot ground, the hookworm larva, that is a rhaptidiform larva, penetrates the skin and enters the venous circulation, and from there into the from heart and then into the lungs, and then it is swallowed with the esophagus, and then it matures in the intestine. And then the eggs are in the feces.
So how many times, how will you examine the stool? How many
Ma'am,
times?
stool for ova, occult blood, and ova for ova cysts and parasites by 3 tests: the benzidine test, WAC test, and orthotolerant test. Which benzidine test is most commonly used, and in that a pea size of the feces is taken, emulsified in water, and 0.3% of benzidine reagent plus hydrogen peroxide is added.
Okay, good, good,
It's very
good.
It is a false negative rate is very like if the test is negative, it is negative, and it is matlab what I'm trying to the sensitivity and the specificity of the test is very high.
Okay.
Suppose if we are not able to do the test, what should we do?
I was coming to the same thing.
We are not able to do the test. Yes, she is. What is the strategy today for anemia?
Ma'am, deworming.
Yeah,
So
you know,
have
every
to do
patient.
deworming. What stage generally we prefer to do deworming?
Ma'am, second trimester by albendazole 100 milligram for 3 days, which is prescribed by the national NEP program, or albendazole 400 milligram once daily. Once start dose can be given.
So now you have, you have a patient in front of you with all the features. Without, she's not in failure. Now, what will be your, line of management?
My line of management will be.
Can I ask one thing now?
Yes,
Suppose if you have diagnosed anemia in first trimester, what are the implications? If you have diagnosed it in second trimester, what are the implications?
Implication like how will I?
If it is diagnosed in first trimester, okay.
If it is diagnosed in the first trimester, I have to see the type of the anemia and the grade, severity of the anemia, ma'am. Whether it is mild, moderate, severe. If it is mild anemia, I will ask her to take oral iron tablets. I will advise her deworming, cooking in iron containing vegetables, fortified salts, and I will ask her how she is taking the oral iron preparations, and I'll prescribe her
First
the proper
trimester,
method.
do you prescribe oral iron?
First trimester.
First trimester, do we prescribe oral iron? क्या देते हैं? सिर्फ फॉलिक एसिड ही देते हैं ना फर्स्ट ट्राइमेस्टर में?
Yes.
No, but if she is severely anemic, then we have to the management.
I have to do blood transfusion.
Yeah, but do you so in first trimester you give or you don't give oral iron?
Ma'am, first trimester we do not give because it increases the nausea, vomiting. So I even after the 14-15 weeks of gestation.
Okay, only that. Any iron, if suppose if you want to give, we don't give anything apart from folic acid, okay? Even iron. Any iron which is recommended for first trimester?
Ferrous ascorbate, ma'am.
Any iron which is liposomal iron. Okay, liposomal can be given in first trimester. I was asking you the implications of anemia. If the patient is anemic from first trimester, how will it affect her pregnancy?
Ma'am, it can, the complications on the mother, antepartum, intrapartum, and postpartum. And
antepartum first now, no?
Antepartum, she can have increased chances of miscarriages in the mother, increased chances of infection, cardiac anemia, she can go in for cardiac failure. Later chances of preeclampsia, abruption.
Cardiac failure will come only with severe anemia.
Severe anemia.
Yeah. So what happens to the fetus?
Fetus may there will be chances of miscarriages, IUGR.
IUGR, you know, IUGR because she has anemia from first trimester. Okay. So IUGR, sepsis, all those things. Yes, she's prone to develop PIH, all those things. In second trimester?
And there is an increased risk of preterm labor.
Exactly, preterm labor. Yeah, that is very common. In fact, no, with anemia, it is very common, preterm. Even in second trimester also, if it is there also can lead to preterm labor. Okay. Yeah. Okay, fine. Now, madam wanted to know how will you manage her now? 34 weeks with 8.4 hemoglobin.
Ma'am, 34 weeks, because she's having moderate anemia, I will prescribe her parenteral iron.
See, just relax. Just tell me, how will you plan your management? She is 34 weeks, and she has not taken oral iron, and she has got 6 weeks to go. What is your aim? She is 8.5 already. And so what is your aim? Why do I want to give parenteral iron to her? Just because she's not tolerant, or why? What is my aim?
I'll assess the cause. Why was she anemic? First of all, I'll ask her whether she was compliant to oral iron or not, or whether she was able to take.
That you have already
That
asked.
is ruled out now.
That you have
Already.
already asked. I am said that you did not ask her which preparation she was taking. Which preparation she was taking, hai na? Has she tried other preparations? Why I should not put her on oral iron and why I should directly take her for the injectable iron? That is my question at this gestation. How much does oral iron will increase if I change the preparation which suits her, and you sit down in front of her and tell her to take like you dots treatment you are giving, you give her oral iron yourself and see that then how will my management, change, and she tolerates it now.
And how much will you give?
एक हम सिर्फ इसलिए चीज के लिए कि उसने बोला कि दे दिया तो हम उसको थोड़ी ना वो कर देंगे, सीधे इंजेक्टेबल पे दे देंगे. How much does oral iron increases and how much does injectable iron increases?
Oral iron increase, oral and parenteral both increases 0.7 milligram deciliter per week.
So generally we take it if no increase in 2 grams of hemoglobin by 3 weeks, we take it as a failure to therapy, right? So how much time we have got now for her?
2 months.
4 weeks, 6 weeks, 4 weeks.
6 weeks.
6 weeks, hai na? So if she gets, she's 8.5, we give her oral iron, try reassess her after 3 weeks, change the preparation which suits her. Then why can't I give her that? Her hemoglobin is 8 grams.
Yes, ma'am.
So why can't I give her oral iron? Why do I want to give her an injectable iron?
You justify your answer if you want to give.
Ma'am, she's already anemia. If she goes into labor, then it will be, and if she comes to us at 8.5, then it will be.
What are the chances of primary gravida going into labor, preterm labor? She's not severely anemic, dear. She is just, mild anemic, I would say. You are saying 8 grams, right?
Yes, ma'am.
So she doesn't even come into the category of moderate. My aim of management will be whether if she's in moderate, I take her to the mild category. If she's severe, then I take her to the moderate category. And if she's mild, then I take her to the normal category. So that's this thing. And my management is very clear that it has to be dependent on the gestation as well as upon the severity of anemia and the time left with me, right?
Yes, ma'am.
So why do I will not agree with you that straight away I will take her for injectable iron. Sakshi, would you like to comment?
See, ma'am, what you're saying is absolutely right, that we have different oral preparations and then we should be able to give the patient different forms of iron. But the thing was this, she came to us at 34 weeks plus 4 days, 8.5. Had we given a trial, then it would have been 36 plus 5 after 2 weeks if you are measured. Then she must have, if she would have been not able to absorb those iron, if she would have been non-compliant.
See, trial, if you are giving another trial, within 1 week, you will know that she can take this preparation or she's tolerating this preparation or not.
Yes, fair enough, ma'am. So that is why, since we were not very sure of compliance, considering that she was not coming to us regularly, we actually thought about that admit her, give her iron so that.
So that is what is the most important thing, that we know that she may not be compliant.
Exactly.
You have to use that word rather than saying that I would like to, try this preparation or that preparation, rather than, focusing on the side effects and not focusing. But we should say we will explain her both the options. But because we feel that she is not compliant, she will not be compliant. So we will like to give her this.
Absolutely, ma'am.
So which oral iron preparation she was taking earlier and which all can we give? What are the various oral iron preparations available?
Ma'am, ferrous fumarate, ferrous sulfate, ferrous ascorbate.
धीरे धीरे बताओ ना, फेरस फ्यूमरेट में क्या होता है, कितना आयरन होता है?
Ma'am, ferrous fumarate has the 30% of hydrated iron, and I'm not sure. Ferrous ascorbate has 40% of iron, ma'am.
उसमें मिलीग्राम लिखा हुआ रहता है ना, 100 मिलीग्राम रहता है उसमें, right? It's a 100 milligram tablet. No, ascorbate. Okay.
Yes, ma'am.
Whereas sulfate is almost 200, right? Yeah. आपको अनम्यूट करना है डॉक्टर प्रतिमा जी.
Preparations you talked about, iron sulfate, iron fumarate, and ferrous fumarate and ferrous ascorbate. And we think ferrous ascorbate should be doing a good job, right?
Yes, ma'am.
And what are the extended release tablets? What does it say? What are the available preparations?
Ma'am, available tablets according to Government of India में 100 milligram iron होता है, तो 60 milligram elemental iron होता है.
वो तो गवर्नमेंट ऑफ इंडिया वाले में है ना. फेरस फ्यूमरेट में कितना है? ऑलमोस्ट इतना ही है. 200 में 66 है ना. फेरस एस्कॉर्बेट में अबाउट 100 के करीब वो कहता है. दैट इज सपोज्ड टू बी सुपीरियर देन अदर थिंग्स. हाँ. So, and what advice will you give to this patient? As you have already said that you will advise them to not to take with the there should be a gap between these tablets. But what will be the will you give a therapeutic dose in this case or a prophylactic dose?
Therapeutic dose.
So what is the difference between therapeutic and prophylactic dose?
Prophylactic dose, we are giving 1 tablet of iron and folic acid, 100 milligram and folic acid of 500 microgram. And in therapeutic, we are giving 2 tablets of iron and folic acid.
And how will you assess the response of oral therapy?
Assess the response. I'll ask the patient about the color of the stools. If she says that she's having black color stool, that means she's consuming iron tablets. And also I'll ask her to show the empty wrappers of the tablets.
तो क्या होगा? उससे क्या होगा? है ना, हमें assess, how will we assess the response, as a scientific basis?
And also she will say that she's feeling better. Patient, her symptoms have improved. And on examination, her pallor has come down. Clinically, she looks better.
Dear, what investigation will you do to assess the response?
Ma'am, repeat CBC and retic count.
Retic count. So that is what I was wanting you to say.
Yeah.
That you should be assessing the retic count. Within 1 week, how much do you expect it to be increasing?
0.5% should be increased, ma'am.
Yeah, so that is the most important thing. And besides that, you will be in 2 to 3 weeks, as we have said earlier, 2 grams of at least increase in the hemoglobin. Hemoglobin increased by 2 grams per 2-3 weeks.
Yes,
at least.
Yes, ma'am.
What are the now? So you have said that you will ask all these history about the patient. Side by side, you will also give her therapy for the worms. And in your case, you have given her the choice. She has opted for parenteral iron. So what are the parenteral iron preparations available and which one we are using?
Ma'am, parenteral iron preparations, there are 3 types: type 1 complexes, type 2 and type 3. Type 1 complexes are iron, dextrin and dextrin complexes. They have the highest molecular weight greater than 1 lakh. The availability of iron is very slow. There are more chances of anaphylactic reactions with those complexes. Type 2 complexes are iron sucrose, which is most commonly being used now, and it increases the iron availability immediately. Plasma half-life is around 5 hours, and molecular weight is 30,000 to 1 lakh. Also, the FCM, that is ferrous carboxy maltose, it is a very good injectable form, and it can be given in high doses. Around 1,000 milligram can be given over 15 minutes. No test dose is required. And the type 3 complexes are our iron sorbitol citrate complexes, which have a molecular weight less than 30,000. And there are more chances of anaphylactic reactions with them, more chances of, and that is why iron sorbitol is not given now. This most commonly used ones iron sucrose and ferrous FCM injection.
But can I ask just one thing, Dr. Pratima? When suppose you said you will be giving a prophylactic or therapeutic dose for this patient? Therapeutic?
Yes, ma'am.
So how many tablets in a day you will ask her to take?
Ma'am, 2 tablets of iron and folic acid.
2 tablets, okay. Is there any disadvantage of giving multiple tablets of iron? In spite of giving, she is anemic, you are giving her iron tablets. But if you still find that her hemoglobin or reticulocyte count is not improving. Is there anything else which makes it not to, that the hemoglobin is not rising? Any new theory?
Then we need to find other causes of anemia. Why after giving so much of iron, her hemoglobin
Do you know anything about hepcidin? Hepcidin is again a hormone, which helps for iron absorption. Okay, just as you are a postgraduate, because once the iron gets absorbed, if the hepcidin levels are low, the iron will be absorbed. Okay, once the hepcidin levels is, blocked, okay, then even if you give repeated dosages, it will not get absorbed. Okay, and the patients with other chronic diseases or infections have high levels of hepcidin. And because they have high levels and inflammation in the intestine, the iron does not get absorbed in them. Okay, so sometimes you find that in spite of giving repeated dosages also, if it is not raising, there is no problem. Even if it is only iron deficiency, even you can give only single days because absorption will be better. Or even they have given alternate days also. So in those patients, it is the hepcidin which is playing a role there.
Yes, ma'am.
Yeah, okay.
Yes,
okay.
Yes,
What is your experience with which IV iron is used in your institution?
Ma'am, Orofa, that is FCM injections we are using.
How frequently you give?
Ma'am, FCM injection 1000 milligram in one sitting, maximum 20 milligram per kg body weight can be given over a week's time.
Maximum 1000.
For all patients, you are using FCM injections?
No, ma'am, because it is costly. So we are also using
the cost only factor.
Is the cost only factor, madam is asking.
हमें तो प्रोफाइलेक्टिकली फिर लगा दे, सभी को लगा देना चाहिए. हमारे यहाँ तो इंसिडेंस इज सो हाई ना, it's 60%. So what is your say on this, that give prophylactic FCM to all pregnant women? तुम्हारी एनीमिक ही नहीं है पेशेंट, 8 ग्राम तो उसका हीमोग्लोबिन है, मतलब इतनी कोई मॉडरेटली या सीवियर एनीमिया नहीं है उसको, है ना. सो एंड
maybe they feel that she is nearing deaths, they have to improve her hemoglobin.
why have you chosen FCM over iron sucrose? I would like to give iron sucrose. That's what I want to know. Sakshi, can you comment on this? I mean, ideally, we don't give FCM.
Ma'am, actually, we gave her iron sucrose. We did not give her FCM. Actually, we gave her iron sucrose only.
Yeah.
Then being that till date with pregnant patients, we still prefer to give iron sucrose as compared to FCM because studies are limited.
No, the advantage of FCM,
so that is why
advantage of FCM is that much lower levels of labile or free iron and allowing large doses of iron be given over shorter time period. That's the advantage.
That's a very big advantage.
Yeah.
See, at the moment, there are studies, all have been done, so many studies have been done, but per se, our DCGI is not approving FCM for antenatal
for pregnancy.
Yes. Absolutely. So that is why we have more safety profile.
That she has to know. She is saying first.
Yes, ma'am. That is why I was surprised when she said FCM, because we have.
No, in public sector also FCM is not available. It is only iron sucrose which is available.
Yes.
So and that we calculate and give it.
So how do we calculate iron sucrose, dear?
Ma'am, by Ganzoni's formula, that is 2.4 into patient's body weight into hemoglobin deficit plus 500 for the iron stores.
Yeah. So how will you give?
Ma'am, 200 milligram and 100 ml of normal saline over 15 to 20 minutes has to be given.
For?
Maximum
on alternate days, same day.
On alternate days, maximum in a week, we can give 600 milligram.
So that all that you have to say, na? Yes, and after that, how will you again monitoring? What will be the monitoring method?
Ma'am, we have to repeat the retic count and CBC after 3 weeks.
After 3 weeks or after 1 week?
After 3 weeks, ma'am.
After 3 weeks, okay. And so now you have given all these, and what are the complications you expect during labor in these cases? Will you induce labor?
Ma'am, it all depends on the obstetric indications. If it is moderate anemia, we can induce the patient if there are no obstetric contraindications.
So now suppose this patient was 4 gram now. You have
Yes,
said
ma'am.
8 gram. I don't agree. I got the repeat hemoglobin done. She was looking very pale to me. She is 4 grams. So what will be your management now?
4 gram, I have to transfuse her with blood.
For all the patients, 4 gram. Okay. Suppose she's 6 grams. She's not severely anemic, very severe. 6 grams, 34 weeks.
What are the indications for blood transfusion in pregnancy?
In pregnancy, if she is 34 weeks of gestation, less than 34 weeks of gestation and hemoglobin is less than 5 with the signs of cardiac failure, I have to transfuse. Or if hemoglobin
with or without 5 grams, I
7,
think you will have to give. Yeah.
Yes.
With CHF,
more than 34 weeks of gestation, if she is coming, then hemoglobin less than 7 grams per day.
In front of you, 6 grams, 34 weeks. Your management.
Ma'am, I have to transfuse her with.
Why 6 grams pe kyun kar? 6 us pe kyun karoge? 6 grams is not severely anemic, na? I mean, not very severe anemic. She is not in failure. Why can't I give injectable to her? Why do I want to give blood to her?
I will assess for signs of any cardiac failure. Agar cardiac failure hai, kuch cardiac decompensation hai, then I will transfuse blood. Otherwise, I can give injectable iron.
Otherwise, you will give. So what will be your aim of giving injectable iron in this case? 6 grams, 34 weeks. Increase the hemoglobin to, what will be your target? See, you have to be practical, we don't want theoretical things, all your anemia is a very simple case, but very difficult. Because it's simplicity is more difficult, to handle simple things, because everybody thinks ki anemia to hum kar lenge, but only thing is ki you have to understand your management is dependent on the gestation as well as on the hemoglobin. So your aim is from severe to change it to the moderate. Right? So how much? So what will you do now?
After injectable iron, I will repeat the hemoglobin after 3 weeks.
Okay. So,
so your aim 8 to 9 grams per deciliter aa jana chahiye.
So from 6 se aapka kitna hona chahiye uska hemoglobin? Your target 8, hai na? So that is what I want you to. So your target should be 8 grams. So you will take it till 8 grams, and then only you will say. So what will now? She's 8 grams. She's gone into labor. What will you do?
8 grams labor during the first stage. I will keep her in proper position, give her IV antibiotics, allow for spontaneous progression, avoid PV examinations, give IV antibiotics. Restrict fluid intake, encourage to take oral fluid. Agar fluid not more than 75 ml per hour, and fetal monitoring has to be done. Then
why did you say 75?
Cross-match blood.
Okay.
And second stage, I'll cut short. Third stage, I will do active management.
Okay. So will you give her oxygen or no? In labor. She's 8 grams.
नहीं देंगे.
देंगे कि नहीं देंगे?
ऑक्सीजन नहीं देंगे मैम.
क्यों? क्यों नहीं दोगे? Does she have a chance of going into failure?
Ma'am, I will assess that. I will monitor her.
You can do her PO2, and if it is low, then definitely you would like to give. But since she's not in failure, then I mean, you can observe and do it, right? Okay,
yeah, that is okay. Cut short the second stage, deliver her faster. Okay, we'll restrict the IV fluids. Okay.
Yes, ma'am.
And cross match and keep blood ready. Okay.
Yes, ma'am.
At how much of blood loss? What is the definition of PPH in her case? Does it differ from the normal definition in an anemic patient?
Yes, ma'am. 500 milligram.
How much? Anemia, PIH, small made woman.
Ma'am, 250 ml blood loss.
250 will be too less. It should be at least 350 ml. Okay. That again depends on her condition. She may not be able to withstand even that much of blood loss.
Yes.
So 350 ml for these patients. Yeah.
How much
So
does
your,
1 unit of blood increases the hemoglobin by how much percentage?
Ma'am, 1 pint of increases by 1 grams and hematocrit by 3 to 5.
Okay. So what will you keep a blood ready? All the anemic patients, you should also say that the blood group should be kept cross-matched. Blood should be available for the patient when she is in labor. In postpartum period, anything specific?
In the postpartum period, ma'am, I will again assess for any postpartum hemorrhage, her bleeding, and antibiotics should be continued in postpartum period, early ambulation, and plenty of fluids.
What about the anemia? She's anemic.
Yeah,
she's
check her hemoglobin in postpartum period, and if it is less than 7, I'll.
So when will you do a hemoglobin checkup in these cases? Postpartum period? Just immediately after delivery?
No, she didn't have any heavy blood loss or anything. When will you repeat?
Ma'am, 48 hours.
क्यों करोगे 48 hours में? What will it tell you in 48 hours? Or will your management change? Do you do routinely for all postnatal patients?
No, ma'am.
So in this case, why do you want to do it after 48 hours?
मैम क्योंकि प्रेगनेंसी ऑलरेडी जो है उसमें हीमो कॉन्सेंट्रेशन मतलब हीमो डाइल्यूशन होता है तो ऑल दोस पैरामीटर्स विल कम बैक टू नॉर्मल सो दैट इज व्हाई आई विल वांट टू रिपीट इट आफ्टर 48 hours.
Or would you like to see, since she is anemic, so definitely her stores are going to be low. Would you like to give her FCM in the postpartum period?
Yes.
IV iron therapy in postpartum period.
Yes, ma'am.
Yes or no?
Yes, ma'am. देंगे.
देंगे. कितना कब दोगे?
On day 3, ma'am.
Okay. And what is the Government of India program of iron management of, making the India iron Mukt India?
Anemia Mukta
Bharat, under that NIPI, that is National Iron Plus Initiative Intensified, is being run by the government, and it has 6x6 strategy, that is 6 beneficiaries, 6 interventions, and 6 institutional programs. So 6 beneficiaries are children less than 5 years, children from 5 to 9 years, pregnant women, lactating women, women of reproductive age group, and children.
Pregnancy
and
what is specific for pregnancy? Prophylactic and therapeutic.
Prophylactic, they are giving 100 milligrams of elemental iron plus 500 micrograms of folic acid, and for therapeutic, they are giving 200 milligrams.
Take minute, don't go fast. 100 milligram iron and
500 milligram of folic acid.
Folic acid for how long?
From the 14th to 15th trimester, after 100 for minimum of 100 days.
So it is basically, we say that 6 months in pregnancy, 6 months postnatally. So that is how it is taken, 6 months pregnancy. And then therapeutic?
Therapeutic, we are giving 200 milligram of elemental iron and 500 microgram of folic acid for cases. And for moderate to severe anemic, we have to decide whether to give them IV or IM preparations or blood transfusion.
Can we give oral iron preparations weekly in pregnancy? What will be the effect?
How much is the total requirement of iron during pregnancy?
Ma'am, per day iron requirement is 30 milligrams. So total is 1000 milligrams is needed during pregnancy.
So can we give weekly iron? It has been explored now, and we can give it, it has been seen that even taking iron on once a week also helps in increasing the hemoglobin. Even for adolescents, that program is there now. What is the program for iron prophylaxis in adolescent? Government of India program? WIFS पता है? Weekly iron and folic acid supplement.
12 पे 12.
12, but WIFS is being every Wednesday or once a week. All the women, all the adolescent girls are being given iron so that their hemoglobin remains 12 at any stage. Yeah. Okay. Anything else, Dr. Sheila Mane, you want to ask?
So postnatally, apart from anemia, what else? Any other problem she can have?
Sorry.
Postnatally, because of anemia, she has increased chances of infection, subinvolution of the uterus.
What else?
Lactation failure.
Yes.
So,
will you insert a PPIUCD? Will you counsel her for PPIUCD? She was 8.4. You have given her iron. Now she has come at term for delivery. Will you counsel her for? She's taken iron. Will you counsel her for PPIUCD? Do you insert PPIUCD in your institute?
No, ma'am.
No, in private, I think they are not exposed.
PPIUCD नहीं लगाते?
No, ma'am. In our hospital, we don't. The private patients they don't prefer.
पर भाई इन लोगों को exposure तो होना चाहिए.
होना चाहिए ना.
So, ma'am, that is why we have actually them to that. There is a very good video of on the website. In fact, Dr. Radhika also showed it yesterday. So we've actually told them. We've also told the method also.
In fact, I think during lockdown, we have put more PPIUCDs because sterilization was not possible. So more and more PPIUCDs were inserted. So she is a candidate because spacing will be required, isn't it? Madam was talking about adolescent anemia because what will happen? The infant remains anemic, then the childhood, then the adolescent, and again she becomes pregnant and comes back with anemia. So that vicious cycle, goes on, right?
Yes.
Yeah. So which type of anemia you have seen as a postgraduate apart from iron deficiency anemia?
Thalassemia.
Thalassemia is a okay. They will have anemia, but it's a hemoglobin. Any other anemia?
Folic acid deficiency, megaloblastic anemia.
Yeah. What are the other problems with if they have severe megaloblastic anemia? What else changes you can find in the peripheral smear? Yeah, sickle cell.
Hypersegmented neutrophils.
Yeah, that will be there. And then slowly what happens? There will be thrombocytopenia. There will be leukopenia, and it will give a picture like a plastic anemia, So once you start correcting, it will get. So you will know that it is not a plastic anemia. We don't see severe B12 deficiency unless and until there is some intrinsic factor deficiency. But folic acid megaloblastic anemia is still common. When you say that she is a thalassemia trait, how much HbA2 you get in her? What is the percentage of HbA2? Because to start with, you started with that, no? And suppose if you have diagnosed her with thalassemia now, what will be your next step?
Ma'am, if she is diagnosed with thalassemia, I will do if she comes to me with...
How much will be the HbA2 in her if she is
less than 3, ma'am?
No. What happens? HbA2 level in thalassemia. It will be more or less?
It will be less, ma'am.
How do you diagnose? It will be more. Why are you getting confused? Madam, unmute कर दीजिए, madam. Madam, unmute हो जा. आपका mute हो.
Jyotsna, one thing which I wanted to highlight is when you are saying that you will give iron sucrose, it is very, very important to, they rule out thalassemia, because we have seen, that patients with 8 grams and you give iron sucrose and the patients, and you find out the stores and it's really bad situation, in those cases. So it is very, very important that in any case you are giving injectable iron, you must rule out thalassemia, especially when it is 7 to 8 grams, borderline side type of things. So I think finally you have presented very well. You have, presenting an easy case is more difficult, as I have said earlier also. But I think we all should remember the 4 R's, which I always say: readiness, that means prophylaxis, and assessment of risk factors for different types of anemia; recognition, that is the hemoglobin estimation and other investigations; response, that is have protocols for the management for dosing of prophylaxis and therapeutic doses, those protocols should be there; and reporting or reviewing, that is measure the response to the therapy. So all these things, if you are there, the management of any disease will be becoming very, very easy for you. So always remember readiness, recognition, response, and review.
4R. Can I just add something? Like the HbA2 level should be 4 to 6%. If it is a thalassemia trait. Okay. And you should also know that there are certain conditions where, apart from thalassemia, also HbA2 might be raised. Okay. Like a HIV positive patient, if she is on lumefantrine. Okay. Then hyperthyroidism. Then megaloblastic anemia. Then pseudoxanthoma elasticum, and hypertrophic osteoarthropathy. Anyway, that is very rare, but there are certain other conditions also where it might be raised. So one more thing I asked you, that if you find out that she is a BTT, beta thalassemia trait, what will be your next step? Because you have to take care of future generations.
Yes, ma'am. If she comes to me preconceptionally, I will do a adequate preconception.
No, even now she's pregnant, you have diagnosed.
I will screen the partner, ma'am.
Yes, very important. You have to screen the partner. Very good. Because it's very important, because if both are carriers, then there are chances. Yeah.
Chances of thalassemia major.
Thalassemia major, isn't it? So it's very important to counsel. I think in North it is more common. So it's not so common in South. And I think in Gujarat and Maharashtra, again, the border, the sickle cell anemia and thalassemia is very common there.
Yes, ma'am.
And in fact, because there are consanguinity is very high, there is some tribal community. So the ICMR has a hospital there, and they have given cards to these people, a pink card and a yellow card. Like depending on if they are a carrier, then they get one color, and if they are the major, then they get. Okay. So that also helps you once they enter the antenatal, they come with a card. So you already know. Okay. And the marriage counseling also happens depending on those cards. Just for your information, because the tribal community border of Gujarat and Maharashtra, it is very, very common, madam, because they come with 3 grams, 4 grams hemoglobin. Okay. So I had been there to train the medical officers for this anti-shock garment. So that's how I know, that is that Dahanu. Okay. So I think Jyotsna has done a good job. So thank you. Yeah. Thank you for the invitation.
Thank you so much.
Jyotsna, well done. Well done.
Thank you.
Hello, Dr. Hiralal Kunar. Hello, Dr. Kunar.
Good afternoon.
Good afternoon.
Thank you, Dr. Sheila, thank Dr. Fatima and Dr. Sakshi for joining us today and for sharing your great knowledge with us. I hope now students will have more clarity for anemia cases in pregnancy. And thank you, Dr. Jyotsna, for your case presentation. I think you have passed with good marks. Now moving on to the next session. It is the last case presentation of today's scientific program. And Dr. Pooja Singh, she is a DNB third year student. She will present case on abnormal uterine bleeding. And to moderate the session, I would like to invite Dr. Harsh Fuller ma'am. She is Vice Chairperson and Senior Consultant, Ops and Gynae Department, SGRH. She had been past Secretary AOGD, ex-Joint Secretary IMS New Delhi, and ex-Secretary NARCHI. She had contributed many chapters in various books. Dr. Hiralal Konar, sir is Senior Consultant Ops and Gynae at GMC and GP Pant Hospital, Tripura. He had been past Foxy representative in 2018 and 2019. National Editor General Board of Ops and Guide India, and he was in ICOJ in 2013. And Dr. Samishta Garg, ma'am is Associate Consultant to Institute of Ops and Gynae at Gangaram Hospital, and Joint Secretary ISOPAB Delhi chapter. Dr. Pooja, have you joined us?
Thank you. I will say hello to Dr. Hiralal Ponar and Dr. Harsh Kullar. And
hello, good evening,
Hi,
Dr.
good evening.
Shilpa.
Good evening.
Good evening.
Dr. Harshad, Dr.
Hello, Dr. Hiralal.
Hey, good evening.
Good evening.
Okay, so
Good evening,
excuse
everybody.
me, Dr. Ila, and I would like to leave now. I have to attend something.
It was a
Okay,
nice
thank you,
session.
ma'am.
I was just listening to that anemia. I think there were so many points. I think these PGs should know that we elaborated on. Thank you, Dr. Sheila.
Thank you.
Thank you, ma'am.
Thank you.
Pooja, please share your slides.
Ma'am, is it visible?
Yes, yes.
Good evening, everyone. I'll be presenting the case on abnormal uterine bleeding. 36 years old female, Mrs. X, wife of Mr. Y, a shopkeeper, resident of Uttam Nagar, homemaker, educated up to 10th standard, belonging to lower middle socio-economic status, presented with a chief complaint of heavy menstrual bleeding since 8 months. History of present illness. The patient was apparently all right 8 months back, following which she complained of heavy menstrual bleeding with the passage of clots and pain in lower abdomen. The pain was dull aching in nature, radiating to back, and it starts on the day of menses and usually subsides on second and third day. Menstrual history. She attended her menarche at the age of 14 years of age. Her LMP was 26 January 2022. Her previous cycles were with the bleeding of 4 to 5 days and cycle length 28 to 30 days. It was regular with average flow and mild dysmenorrhea was present. In the present cycles she has a bleeding for 6 to 7 days and the cycle length is 25 days. It is regular with excessive flow. She changes her pad 6 times per day, which is fully soaked and associated with some social accidents and absence from work. It is also associated with the passage of clots and mild dysmenorrhea. She also complains of easy fatigability. There is no complaint of abnormal or foul smelling discharge per vagina, no complaint of increased frequency of micturition, retention, or burning micturition, no complaint of constipation or tenesmus, no swelling of lower limbs or dyspareunia. She doesn't give history of loss of weight or appetite, no history of bleeding from any other side, and no history of intermenstrual bleeding. Marital history, she has been married since 14 years. Contraceptive history, no contraceptive in use. Obstetric history, she is para to living to, both female, full-term normal vaginal delivery at government hospital. There was no history of any instrumental or postpartum hemorrhage. The last childbirth was 10 years back. The treatment history, she gives a history of taking oral medication for 3 days during menstrual cycles since 8 months. Past medical history, she's a not known case of diabetes, hypertension, thyroid disorders, cardiovascular disorder, bleeding disorder, any malignancy or any chronic disease. Other than 3-day medication during period, the patient is not taking any other medication. Past surgical history, no history of any surgical or gynecological intervention done. Family history, her mother underwent hysterectomy in view of heavy menstrual bleeding at the age of 43 years old. No history of any menstrual abnormalities in sisters. Personal history, she consumes mixed diet. She has normal bowel and bladder habit, normal sleep pattern, no addiction. General examination, the patient is obese, height is 158 centimeter, weight 88 kgs, making her BMI 35.5. Pallor is present. JVP is not raised. No other signs of congestive cardiac failure. No icterus, cyanosis, clubbing, or lymphadenopathy. She is afebrile. Pulse is 88 beats per minute, normal volume and rhythm. BP is 120 by 80 mm of Hg. On thyroid and breast examination, no lump was palpable. Systemic examination, cardiovascular system S1 and S2 was heard. No murmur was heard. Respiratory system, normal vesicular breath sounds were heard. On abdominal examination, on inspection, the abdomen appeared normal. Contour was normal. It was not distended. All quadrants moved equally with respiration. No scar, sinuses or distended veins visible or pulsation. All hernial sites were free. On palpation, suprapubic mass 3 centimeter above the pubic symphysis, probably of size 12 to 14 weeks, noted in the midline. It was smooth surface, well defined margins, except the lower border could not be made out. Firm in consistency, non-tender, and side-to-side mobility was present. On auscultation, normal bowel sounds were present. Percussion, no abnormalities were detected. Pelvic examination, on inspection, the external genitalia appeared normal. Per speculum examination, vagina and cervix were normal. No polyps were noted and no abnormal discharge was seen. Bimanual pelvic examination, uterus was anteverted, 12 to 14 weeks size, smooth, enlarged, which is same as the same palpable per abdominally. Side to side mobility was present. All furnitures were free and it was non-tender. Per rectal, no nodularity noted in the pouch of Douglas. Summary, Mrs. X, 36 years old, female, P2L2, coming from Uttam Nagar, socioeconomic status, lower middle, with a complaint of heavy menstrual bleeding with passage of clots and normotensive, normal pulse. On abdominal examination, 12 to 14 weeks size, midline mass, smooth, well-defined margin, except the lower border could not be made out. Firm inconsistency, non-tender, side-to-side mobility present. Pelvic examination, normal external genitalia, healthy cervix, and bimanual examination, 12 to same as confirming the findings of abdominal examination. And the provisional diagnosis, it is in case of abnormal uterine bleeding. Most probably adenomyosis of fat.
So Pooja, why you're saying that it's a case of AUB, abnormal uterine bleeding?
Ma'am, abnormal uterine bleeding because she complains of, because her cycles have been they are regular, but she has complaints of heavy menstrual bleeding with the changes of pad more than 6 times a day, which are fully soaked, and with pain during the menses, and with the social accidents, and that's why I'm calling it.
Now you've told that she's got heavy menstrual bleeding.
Yes, ma'am.
And she soaks around 6 pads per day.
Yes, ma'am.
Do you think that the total loss of blood occurs in one cycle?
Ma'am, if we follow the pictorial blood loss assessment chart, according to that, one sanitary napkin, if it is fully soaked, the value given to it is 20 marks. So in this case, she changes 6 pads per day and her cycles are 6 to 7 days. So it is more than, suppose the first 3 days or 4 days she heavily bleeds. So then 22 into 3 to 4, it's more than 100. If the gross total value of the, if the total points are more than 100 at the end of the menses, then it is heavy menstrual bleeding. And ma'am, one sanitary...
What's the normal blood loss during a cycle?
Ma'am, normal blood loss in a normal menstrual cycle is around 50 to 80 ml per cycle. And ma'am, one sanitary pad, it soaks, when it is fully soaked, it is around at 15 ml it contains. So if she changes 6 times, then it is more than 80. So that's it.
Mm-hmm. Dr. Hiralal, would you like to ask?
Right, Pooja, thank you very much. Detail of history that you have presented a little bit of modifications I would seek rather. Other I often tell the everybody, the students, that too much of negative history, no history, no history, no history, probably in postgraduate examination not appropriate, because you need to highlight the salient features in presentation. You know, though history we listen to this, but it is not that you keep on talking something irrelevant. So to make it relevant and precise, too much of negative history, we don't need it. That even including that of the history area, and no constipation, something, this is not important. Now coming to the point of discussion, next to Professor Khullar, Harsha, that she has asked regarding the define that AUB. Another thing you brought in the discussion way, that is the excessive menstrual bleeding. She suffers from excessive menstrual bleeding. You know, from your history, 6 pads, fully soaked, 6 to 7 days like that. So have you got any clear-cut idea? There is a overlapping, you know, all definitions, what has been made in this field of abnormal bleeding, there are overlapping. So how precisely you say that is the abnormal uterine bleeding? How precisely define that excessive menstrual bleeding? Any idea about that?
So if woman complain that she bleeds for more than 3 to 5
beyond the normal range of duration,
yes, sir,
amount, and the cyclicity or regularity is that of the abnormal.
Yes, sir.
Irrespective of the amount, that small amount and the heavy amount. Whereas excessive menstrual bleeding, that such an excess that affects the woman's social,
yes, sir,
physical, and that day-to-day activities, quality of life. So that is the excessive menstrual bleeding. So basically there is a lot of overlapping between the two. Another question we often talk about, earlier days we used to often talk about DUB, dysfunctional uterine bleeding. This is another area, probably because of this FIGO new classification, that we are moving off from that of this DUB, because that is another entity probably that has not been considered well in that of the new definitions of the abnormal uterine bleeding. Now then, you have come to the diagnosis of AUB, adenomyosis, or fibroid. I would request you to convert the term fibroid to that of leiomyoma, because
yes, sir,
AUB that has been described by FIGO and ACOG, that considers the leiomyoma, and then they have gone with different subdivisions of L, AUB-L, AUB-A, AUB-L, like that.
Yes, sir.
And that's good. So how you think that possibility of kept in mind possibility of adenomyosis and that the possibility of fibroid?
So on per abdomen examination, there is a midline mass, which is around 12 to 14 week size. Then on PV examination, there is the uterus is a smooth surface, and there is a well-defined margin, and the lower border is not, and it is firm in consistency, non-tender, and there is a mobility present. So on basis of this, I came to the conclusion that either it is adenomyosis or a single fibroid.
Right, you are. If you are given the opportunity of investigations, how you go about it?
So first of all, in this case,
one thing to remind you, when you were going for the speculum examination, inspection, that's a good way of inspection, speculum examination, and then bimanual examination. You need to mention about the smear, you know, the cervical smear, that whether it has been taken recently, if not, that you have taken one, like this way. Carry on.
For investigation, first of all, I'll conduct the blood investigation, which will include the complete blood picture, then coagulation profile or BTS-CT. Then I'll do the blood sugars, thyroid function test, then LFT and KFT, and then urine routine and culture. And in this case, I'll also perform the, since the patient has come to the OPD, I'll do the pap smear. And in imaging, I'll advise her to go for ultrasound, most preferably transvaginal ultrasound. And
right, you are right. You are. We will stop here. And the way of investigations that you have mentioned, one word, coagulation profile.
Yes, sir.
In your case, how, they often we are interested more that of your presentation, how you think about. So as you have included that of the need of coagulation profile, why you think so?
So,
And if you do the coagulation profile, what you are going to do?
To rule out any acquired hematological disorders, that's why I'm doing the coagulation profile.
Pooja, now then, what makes you to think about the hematological conditions for this woman? That she attained menarche, that she had regular cycles, that she had this childbirth, and all these things going on smoothly. What makes you to think that some hemorrhagic disorders needs to be excluded for this woman?
She may be suffering from any liver disorder, which may, she's on any oral anticoagulants, or
she is not an anticoagulant. You have said so nearly more than 10 of negative factors. So I believe that there's nothing there. So who are the women where we should keep in mind, given an example to give you the idea, say for example, she had her menarche. Did she bleed heavily since the menarche?
Yes.
It was not. Did you say that? No, nothing there. Did she had any history of some bruising, some gum bleeding, something? There is none. You see frequent bruising once or twice a month, or some gum bleeding occasionally, or some unusual bleeding for this of, or the childbirth postpartum hemorrhage. These are the clue that gives you that maybe that you are appropriate to go for, definitely we need to go for the right you are. So she didn't have anything that probably for her case, well, you can discuss, but keep in mind that you should be well guarded that history, that what suggests or what doesn't suggest. Now coming to the, if you think of this coagulation, what are the parameters you are going to do?
First of all, I'll check the platelets, then clotting time and bleeding time to be checked, and in coagulation profile, PT, APTT, and INR.
Well, you can do, but probably for her case anyway.
It's not needed.
Professor Harsha, then coming to the original issue of your diagnosis, adenomyosis, and whether I would call it leiomyoma, how we can go about her at this lady of 36 years, did you say 36 years?
Yes.
She's
36 years.
36 years, right? You
On the investigation, blood investigation, and LBC, and then transvaginal sonography. And in this case, as the woman, she is obese, there is a risk factor. So I'll suggest for endometrial biopsy, sir, in this case.
No, your plan is to, if you prefer to go for this transvaginal sonography, and what benefits you are going to, what is the areas that you are going to look for using the transvaginal sonography?
Yes, sir. So in the uterus, I'll look for the endometrial lining, endometrial thickness, and myometrial thickness. Then for the any space occupying lesion in the uterus, then look for the adenexa, and yes, sir, and the POD.
Right.
And the obesity.
Can I ask one question? Suppose you are suspected is adenomyosis on ultrasound. Did you find something also in the uterus?
On adenomyosis?
Yes. What would be the picture?
Yeah.
Ultrasound picture in adenomyosis?
Ma'am, in the adenomyosis, there is a heterogeneous criteria, opacity. There is a intermittent shadowing of ultrasound rays, and then there is a junctional is thickened. Endomyometrial junction is thickened in case of adenomyosis, and there is cystic.
Yes, that is very important to see the cystic. Yes, the endomyometrial area.
Yes, most probably on the posterior wall.
And secondly, in cases of fibroid, you will find that they are in the world appearance.
Yes, ma'am, and they are homogeneous mostly.
Yes.
Coming back to your TVS again, endometrial thickness, that you are interested to go for endometrial biopsy also.
Yes, sir.
What thickness raises your concern that yes, she should be definitely we should take the sample for the endometrium, meaning that what thickness criteria we usually follow such a patient of abnormal uterine bleeding.
Sir, endometrial thickness of more than, so it depends on the cycle day.
Overall, say around if it is 4 to 5 centimeter, probably it is not that important. But again, then if it is 9, 10, 11, 12, then definitely it indicates proliferative endometrium. More than 19, obviously risk of carcinoma of the endometrium is high. So considering the thickness of the endometrium, that guides us who are the high risk cases for that of the endometrial sampling or the biopsy. Now question is, how do you do it?
So endometrial aspiration.
Well, the way you are doing in your hospital, or you feel that it should be done for this case.
So in usually the office biopsy can be done. So in our hospital, we combine it with the hysteroscopy in the same sitting, so that it can be a therapeutic as well as a diagnostic and therapeutic.
What did you say? What did you say? Say it again.
So in our hospital, we combine it with the hysteroscopy, so that in the same setting, it can be diagnostic and therapeutic.
Meaning the diagnosis and the therapeutic of the endometrial biopsy or curettage or something, what you are going to do?
Suppose we do it with the hysteroscopy. Suppose if any area is suspicious, or we find any polyp or any submucosal fibroid, which can be removed at the same sitting, and sample can be taken. Yes.
No, how do you take the sample? I would say, for example, otherwise endometrium is unremarkable. Only thickness is there that you need to take the sample of the endometrium. How do you take it?
So in office procedure, the patient is first of all the patient consent is taken from the patient, and patient is explained the procedure. Then the patient is made to lie in the lithotomy position. The area is cleaned, draped, and then the Cusco's speculum is Sims speculum is inserted, and then the anterior lip of the cervix is held with the valcellum. Then the pipple aspirator is
no, we are not that much interested with the procedure. Believe that you are doing day by day that taking these samples. So how specific that the endometrial pipple sampler is? Accuracy, in terms of accuracy, and what's the limitations of pipple sampling?
So it is highly accurate. So exact value.
Correct. You're right. Limitations.
Limitations. So it is the patient can be comprehensive. It is a painful procedure, and sometimes the negotiation, there may be a cervical stenosis. So the negotiation of the people can be difficult, and then there may be bleeding hemorrhage, which cannot be it may be difficult to control at the OPD basis, and then it may be a negative procedure. We may not obtain any sample. That limitation of office procedure.
So no, mostly that sample sometimes becomes inadequate for review. Anyhow.
That is what I said.
Yeah. Anyhow, now then about coming back to our own questions of adenomyosis and the leiomyoma of the uterus, how do you proceed with this? That sonography says mostly it is an adenomyosis.
Adenomyosis.
Sir, what is the point which you told in the history which is going in favor of adenomyosis? I think you have given one history.
Yeah.
Ma'am, dysmenorrhea.
Yes.
Because it starts on the day of menses and peaks around second day and ends by the second and third day. So it is probably spasmodic.
But dysmenorrhea can be in cases of fibroid also. Suppose she is having submucous fibroid.
Ma'am, it is 12 to 14 weeks size. If the fibroid, it may be larger. Usually adenomyosis, they don't go beyond the 14 weeks, and they are smooth surface and well defined. The uterus is usually closed.
Very rarely this thing adenomyosis we have seen, they can be very, very big also.
Yes.
Right? Very rarely.
Yes. So for the management purpose, first of all, after the investigation, depending upon the patient's requirement. As she is a reproductive age female, in this case, I'll offer, first of all, I'll go with the non-hormonal treatment, medical management, which will include the non-hormonal treatment like NSAID,
Now, you
prostaglandins.
see, your decision would be depending on not only that of this reproductive age group, what's the endometrial sample came, histopathology.
Yes, sir. Yes, sir.
Moreover,
Suppose,
moreover, Pooja, that you need to consider that so far, if I can correctly remember, her BMI was something around
35.3.
Did you
She's
say
obese.
30? Yes,
35.3.
35 so far I remember.
Yes, sir.
BMI is high.
Yes, sir. So
And
that's why.
anything else that we have got in that of the investigations that you have performed?
Sir,
Is it a case or it is also virtual?
so it is a case. So I have her investigations.
Right, you are. Now, we would be interested to know, especially that of the thyroid status and that of the blood glucose status.
Yes, sir.
Talk about. Well, fasting is 93, so far I can see, and hemoglobin is really anemic, and thyroid status so far within the normal range, and what I would say, anti-endometrial thickness 6.6, heterogeneous mass of, there is a mass they have noted now,
Yes,
submucosal fibroid.
Actually, sir, this ultrasound was not very good.
Yeah. Ovaries, normal
and it
dimension.
was old.
Right, you are. So basically, it is a case of submucosal fibroid, leiomyoma.
Yes, sir.
And I don't know whether you have performed this postprandial one, 93, or.
So these were the reports which were available with her. And after that, we have performed LBC, and it came to be NILM negative, and endometrial biopsy was planned for this period.
What you have thought about her BMI then?
So she falls in the category of she's obese, so that's why, sir, there is a increased risk factor, and she already complains of passage of clots and heavy menstrual bleeding, so she's the candidate for the endometrial biopsy, and depending upon the endometrial biopsy report, if it comes, suppose
you have got the report? No, you are waiting.
Sir, no, sir, I have not got the report.
Right. You.
So, sir, if the report is, if the endometrium is in the proliferative phase, so it is an anovulatory cycles. So that in that case, I'll be giving her progesterones, and if the report is in a secretory phase, so that in that case, so antifibrinolytics or NSAIDs, or to control the bleeding, in that case, combined oral pills can be given.
Pooja, in this case, ultrasound is showing that there is a submucosal fibroid. Suppose this report is correct.
Yes, ma'am.
Still, you would like to put her on this thing, medical treatment only?
Yeah.
Would you like to do hysteroscopy inside?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Hysteroscopy, so that because it is resectable. It can be resected through hysteroscope. So I'll do the hysteroscopy and try to remove the fibroid.
No. Regarding, you see, Pooja, that if we go by the classifications of the AUB itself, or
Yes, sir.
there are other classifications, I believe you must be aware that of these the other classifications of these uterus, the fibroid in the uterus, that considering the scope of management, meaning that the submucosal,
Yes, sir.
amenable to
Intramural.
yeah, are you aware of that?
Yes, sir.
Fibroids, worm shakers.
Ma'am, like the fibroid is divided, then the first one is the type 0, that is the pedunculated. Then type 1, it is less than 50% intramural. Type 2, it is more than 50%.
That's okay. That we are not going for that to tell us all the details. So you are aware of that. Is there any other classification that you are aware that they have also classified the the myomas in terms of topography, size, penetration, invasion, like that? Otherwise, there is a classification that step W that
No,
says
sir.
about the size, topography, all these things. Anyhow. So what about your case that you are planning?
So in her case, I'll in one sitting I'll do the hysteroscopic myomectomy. And so first of all, no sir. First of all, I'll so as it is the submucosal fibroid and the size is 4 centimeter. If the patient, I'll offer her medical management and surgical management also. If the patient is willing for surgical management, then I'll go for the hysteroscopic myomectomy.
No,
If not, then
Pooja, I will stop you here. If
Yes,
you offer her the management options of medical management and the surgical management, probably she would ask you in the long term how I am going to get the benefit in either of the procedure, meaning that how far the medical management is going to help me or surgical management is going to help me.
Yes, sir. So
And the medical management, you see that it may be that you have to continue the medicine, otherwise you won't work. Then again, she goes back to her own problem. So
Yes, sir.
how you talk to her with this information that the situation and the pathology?
So as she's only 36 years old, so first of all, I'll ask her ki whether she is willing for the more pregnancy or not. So in that case, my treatment line of treatment will.
Our
depend.
last childbirth, so far I could remember again, it is 10
6
years.
years.
Yeah, did you say that one? So if it is so, probably I believe that she has got 3, no?
2.
Two.
Yes, sir.
2. No, I don't think that. Anyhow, you need to
Yes,
ask
sir.
her that her interest.
Yes, sir. So that in that case, because there may be medical management may fail. So in that case, we have to go for the surgical management. And if she is planning for keeping her pregnancy, for desire for the pregnancy, then in that case, myomectomy can be offered to her. And if the cavity is not distorted, then in that case, the LNG IUS can also be offered. If she is not willing for the medical management.
How you feel that LNG's IOD is going to help her?
So this will solve her heavy menstrual bleeding, and this may reduce the size of the fibroid, but not that much, but it may help. And then it will provide her and this so symptomatic relief. And she doesn't have to deal with the daily intake of the oral medications or any surgical treatment. It can be put in the OPD basis and can be removed after 5 years or whenever she wants.
Well, that's true that it is entirely on the situation of the long-term basis, her desire and the plan and the provisions of approach different management issues. Now, if we consider what are the other areas you know of regarding this AUB, coming to the broad heading of that we are discussing, or excessive EMB, excessive menstrual bleeding, the other could be the reasons. Apart from that, your case that submucosal fibroid uterus.
So the palm point classification, of which the P is the polyp, A is the adenomyosis, L is the leiomyoma, M is the malignancy and hyperplasia. That is, these are the structural causes. Then non-structural causes or the functional causes are the
No,
points.
that's okay. That's a good idea that you are keeping in mind everything. So if I ask you regarding the iatrogenic causes.
Yes, sir.
Then in that case, that sometimes we face the problem of iatrogenic causes.
Yes, sir. Suppose there is, if the patient is on oral anticoagulants, if there is a IUCD inserted.
Say it again.
So if the patient is on the oral anticoagulants or IUCD is inserted or she is, if she is taking OCPs and she is not compliant with the medication, so in that case, these will be included under the iatrogenic classification.
And that of these not yet identified?
So this include mainly the endometritis or the
endometriosis has got its own area there. So
sir,
have you heard of some uncommon causes rather, that of the arteriovenous fistula or something like that?
Yes, sir. AV malformations.
How it causes bleeding?
So there is a denuded surface of the endometrium, and the venues and there is abnormal connection. Sir, exact I don't know, sir.
How this? What about your information regarding the AV fistula?
AV
the cases. Who are the cases? How they present like this?
So in case of scar ectopic, in that case, AV malformation or AV abnormal connection happens, and they present with the abnormal uterine bleeding.
Even that of the
after MTP and all? Can
Yes,
it
ma'am.
be after MTP?
Yes, ma'am. After MTP, it happens, or suction.
Why they are formed?
Yeah, sometimes a difficult cesarean section or that of these malignant cases, they often develop this. Or it may be even congenital. It may be some individual with congenital. Have you come across, have you any idea regarding how do they present and how it could be diagnosed or be managed?
So I have seen a case. It was MTP was suction evacuation was done, and after that the patient kept on bleeding, and on MRI it showed there was AV malformations and abnormal connections were there.
Was it MR angiography or was it MRI?
Ma'am, angiography, ma'am. Angiography.
So before that, I think you have to rule out that there is not retained products of conception.
Yes, ma'am.
Right?
Yes, ma'am.
Angiography is the best mode of diagnosis, you know, that of these AV malformation.
Yes, sir. So in that case, we have done uterine artery embolization was done, and since the patient was not willing for any surgical, and there was chances for uncontrolled bleeding, so uterine artery embolization was done.
What was the treatment done for that case?
Uterine artery embolization was done.
Embolization. You have got any idea regarding the uterine artery embolization?
Yes, sir. So
What are the other cases that it could be performed?
So it can be performed in leiomyomas, in case of in case of
This
even
case, now Pooja, just for a second.
Yes, sir.
In this case, your data you have presented with that of the submucous myoma.
Yes, sir.
Could she be treated with uterine artery embolization?
Yes, sir.
How you say so? What are the contraindications of uterine artery embolization?
The contraindication for the uterine artery embolization, if the patient is willing for future pregnancy, if she is pregnant at that time, if there is any infection, and we have to rule out.
So in our case, your present case, you are not sure, probably we haven't decided whether she's looking for any pregnancy or not. Maybe
Yes, sir.
not, because last child was 10 years, probably she would have taken the other one if she desired so. So
Yes, sir,
maybe,
yes, sir.
but again then, UAE has got its limitations. It cannot
sir.
be used for all the cases like this case. Loudly. What are the limitations? Any idea?
Yes, sir. The limitations of uterine artery embolization pregnancy, it is a contraindicated. In any undiagnosed pelvic masses, then PID, endometrial hyperplasia or atypia, any carcinoma or any that infection at the site, and
Now,
and the uterine size more than 16 weeks. Yes, sir.
now, in a way of discussion, you presented that if this endometrium is proliferative or is anovulatory bleeding, you will prefer for that the progesterone.
Progesterone, yes, sir.
And if it is that the secretory endometrium,
Yes, sir.
you would like to go for?
Antifibrinolytics or combined oral.
How you justify your statement?
So in anovulatory, since there is an absence of progesterone hormone, so there is a unopposed estrogen axis, which is causing the proliferation of the endometrium and fragility of the endometrium. So there is a heavy menstrual bleeding. So in that case, there is a estrogen. Just we have to provide with the progesterone so that it controls the bleeding. While in the secretory phase, there is a presence of both, but yeah, in that case, there may be prostaglandin imbalance. So there is a heavy menstrual bleeding. So in that case,
if there is secretory endometrium, you see the bleeding pattern.
Yes, sir.
This
It is
woman,
regular.
is there any possibility that she could be with a say ovulatory bleeding? What is the common one that of abnormal uterine bleeding? If we go by the classification of ovulatory bleeding and non-ovulatory bleeding, which one is the dominant one?
Anovulatory.
Anovulatory bleeding is to the extent of 80% of the cases.
Yes,
And the presence of myoma already suggests that it is a hormone-dependent tumor,
yes, sir.
and
Yes.
she is not going to make it. And her health, all that of the BMI,
Estrogen,
all
yes.
suggests that she is in the phase of. So how you are going to get the benefit, giving some that of the antifibrinolytic agent?
So yes, sir. No, sir. I'll go with the
Would there be
hormonal.
any place that of the drugs that being used in the treatment of leiomyoma?
Yes, sir. The hormonal treatment like progesterone or combined oral pills, then sir, mifepristone, they reduces the size of the myoma also and decreases the amount of bleeding. Then also sir, there is this even anastrozole aromatase inhibitors can be also given. Then
Would there be any place of GnRH analog?
yes, sir. Yes, sir. GnRH.
Now question is, how long we are going to get this benefit of this control of bleeding using that of these different medical agents?
So 3 months. We usually give for the 3 months, and then
So there is an area of debate and controversy again. This medical management, if it is a case of submucous leiomyoma, for this situation of her age, how long we should continue when these drugs, not that only they are expensive, but also they have got the side effects too. So keeping in mind, for her case, decision would be a bit difficult to make. Dr. Harsha.
In cases of type 0 and type 1 submissing fibroids, I think uterine artery embolization should not be done. We should remove the cause. I think the this hysteroscopic myomectomy can be done in cases of type 0, type 1. Because uterine artery embolization is not going to, because it will slough out otherwise and shield bleeding.
There could be a possibility, yes. Anything else? Dr. Harsha?
Yes, sir, you are asking, please ask. Huh?
Any other thing you want to know? Anybody has got in the audience question?
Pooja, can you tell us that this ulipristal and all, should it be given and what investigations should be done? And what side effects?
Also say it again.
Side effects of ulipristal and what?
All right, definitely. Ulipristal probably it has been stopped, and again it has come back with the limitations of duration of therapy, 3 months, 1 month off, like that. For the temporary phase of benefit, controlling bleeding
pre-surgical
and improvement of the health of the woman, maybe, but definitely
not for the long
has not been permitted. That's the reason I was concerned. Even if you are using that of the GnRH analog, you can't continue it.
Yes, sir. Advanced therapy should be
like
given.
that. One hand it has got cost, other hand it has got the side effects too. So this medical therapy for such situation probably is a bit difficult situation.
I think for this, LNG IUS will be the best thing.
Best thing. Because if the cavity is not distorted, then we can definitely go with the LNG IUS.
Now, what are the limitations for LNG IUS, Pooja?
Ma'am, the uterus size should not be more than 14 weeks, and the cavity should not be distorted.
Yeah.
And the patient should be compliant to follow up. There should be no any active infection, vaginal infection, and and then she should be made aware there may be on and off spotting.
Yes, that's very important.
And she should be made aware how to check for the thread and to report to OPD in case of bleeding persist or the pain persist.
So it can be used for both, for fibroid as well as for adenomyosis also.
Yes, ma'am.
Right? So in
Yes, ma'am.
adenomyosis, in how many percentage of the cases you can find that there is endometriosis of the adnex also?
Ma'am,
Can it be there?
Ma'am, 25 to.
Can it be there?
Yes, ma'am. Yes, ma'am. There is a association of both. Ma'am, exact, I don't know, ma'am.
And with fibroid endometriosis association?
Ma'am, not so much as much with the adenomyosis, but yeah, they may be present.
In almost 5% of the cases, you may find that. Okay.
Now, any questions from your side or that the participants to the reviewers?
So there is no questions in chat box currently. I'm just checking.
AVM. Yes. Somebody has asked for AVM.
So how are you going to follow up the patient of AUB? Suppose you have found that this patient had cystic glandular hyperplasia or hyperplasia, right?
Yes,
so
yes,
you put the patient on progesterones. She's young patient, 36 years, she's obese. So how are you going to follow up this patient?
Ma'am, I'll call her after 3 months and I'll do the endometrial sampling again. No, ma'am, in this case, after 6 months, and I'll call her for the endometrial sampling. And in the OPD,
Before that, would you like to do the ultrasound?
Yes, ma'am. PV examination and ultrasound, and yes, ma'am. Ultrasound should be done to see for the size of the fibroid. And ma'am, ma'am, for the routine examination also, like PV.
From the chat book, somebody has asked that what are the contraindications of uterine artery embolization?
Yes, ma'am.
We have discussed that or no?
So somebody has asked
pregnancy, if she desires pregnancy, presence of infections, all these are contraindications.
So somebody has asked about explain AVM.
Sorry?
So explain AVM.
I couldn't get you.
Arteriovenous malformation.
Arteriovenous malformations, honestly speaking, as we have discussed already, it could be iatrogenic in forms of that you have said that MTP procedure or difficult cesarean section, presence of malignancy, cervical, endometrial, or that of GTN even, that develops, and congenital. So these are the different areas that so far we know. And usually the problem is presence with abnormal uterine bleeding. And sometimes the bleeding is heavy and alarming bleeding. That's a major area of concern for AV malformation. So often, if you go for the usual mode of diagnosis, you miss the diagnosis. Unless you are focused to see using that of the transvaginal sonography to that of this lower segment, seeing some tubular structure, or using the Doppler, that of the increased vascularity, or CT contrast enhanced CT, or the MRI that you have said, that makes the diagnosis. Now, once the diagnosis is made, but best way of confirmation of diagnosis is the angiography. And the mode of therapy, by and large, most of the cases ends in hysterectomy especially. And otherwise, when we tend to preserve the uterus, that of this, because of the menstrual function, that this urinary embolization is the alternative. But what has been, as we have discussed, that urinary embolization, by and large, those women they are planning to get the baby again, probably it is not that optimum. But what has been again observed over the years, that pregnancy has been reported. Earlier it was it was recorded many side effects in forms of that of the miscarriage and even ovarian failure, premature
Yes,
ovarian failure has been
premature ovarian
discussed. But those things are rare and majority of the cases recover well. Pregnancy has been recorded. So nothing more that we don't have our personal experience. Whatever I have said by the review of literature only, but I have come across cases such alarming bleeding, and especially in the puerperal phase, following difficult cesarean section and then alarming, and then we ended up with the hysterectomy. So these are the cases with the experience, but regarding the long-term effect of UAE, urinary embolization, what literature has recorded, we have come across. Nothing more that I can say.
Somebody has asked about the fibristol.
Also,
Fibristol, ulipristal.
ulipristal probably we have
We have already discussed, Vese. And it should not be given in patients who have got liver diseases.
Sure.
We have reported 3 cases of hepatic failure.
Hepatitis.
As such, liver disease may cause abnormal uterine bleeding. Pooja, any idea?
So due to the anticoagulants which are found in the liver, they
Moreover, the steroids are metabolized in the liver.
Yes.
If the dysfunction is there, estradiol metabolism is affected. Serum estrogen level is high. Estradiol level is high. So these women go for that of these endometrial proliferations and hyperplasia, and they end up ultimately with the bleeding. Apart from that of the coagulation factors, the metabolic effect of liver dysfunction itself, hyperestrogenism. Similarly,
yes, same with the renal failure also. There is a
renal failure also.
excretion of the estrogen and progesterone. So in that case also.
Pooja, there is another question. 16-year-old girl with irregular menstrual cycle every 15 to 20 days cycle for 5 to 6 days. How will we proceed? She has not mentioned about the age at menarche.
Yes, ma'am. It is my most yes,
puberty.
Puberty menorrhagia. Ma'am, in that case, the ideal would be, ma'am, combined oral contraceptive pills.
But before that, because she specifically 16-year-old girl, so here comes what Dr. Hiralal was telling, that you must rule out any congenital
hematological disorders.
Hematological disorder. So that is very, very important.
Von Willebrand factors or
yes.
For this case, to my mind, it would be obviously it depends on her choice to go for endometrial resection and resection of the myoma at the same time. This could be
endometrial ablation techniques.
Yeah, that we are doing as a management of abnormal uterine bleeding. That endometrial resection, that it is not that popular in our country, but in outside England it is very common, and many of us in Calcutta we are doing. So endometrial resection is an option, and at the procedure we will resect. I believe that Sir Gangaram has got this good endoscopic center, so
PCR is being done.
and the same time myoma resection could be attempted. So this is one option for preservation of the uterus as well as fertility for this woman. This could be.
But sir, girl is only this thing 16 years. So in this case, I think Mirena, that low dose Mirena, that will be better. I don't remember the name of that, which is for that young.
Is there a question you are answering? No.
No, sir, I'm just asking you. But in this case, 16-year-old girl having this thing every 15 to 20 days cycle for 5 to 6 days. So how are we going to proceed? But in this case, we are not going to do TCR.
No, ma'am.
No. I am talking about Pooja's case that she has presented.
Pooja's case, yes.
Pooja's case at this age of 36, maybe she is a case of resection of the endometrium as well as resection of the myoma, submucous myoma. That can
Somebody
help
has answered my
preserving the
question.
uterus as well as fertility.
Tyla.
And for your case, the adolescent girl, maybe if it is the coagulation or hemorrhagic disorders are excluded, she could be given a long-term progesterone. That will help her, don't you? Or even that of the, she's 15, you said 16 or 15?
16, yes, sir.
Maybe given the combined hormones.
No, she's not a case of PCO, polycystic ovaries.
Commonly.
So that is very, very important in this age.
Sure.
Good evening. Dr. Konar, good evening, Dr. Ashok Kumar.
It looks like I have not seen, sir. It looks Professor Ashok Kumar.
Yes, sir. Good evening.
Your voice resounds to my heart.
Yes, sir.
Good, sir.
Dr.
Your time
Ashok,
is
you
on,
can
na?
put your inputs.
I'm waiting for my turn, sir.
Sure, sure. We are waiting for you.
No, I'm waiting.
No, great. You can start. We are over.
No, you had a very good discussion. Yes.
Anybody has got any questions? Otherwise, you will stop and sir will take over.
Sir, I think most of the questions have been covered.
Yeah, we have deliberately covered the other areas, but for this case, Puja management, my feeling is this: she is a good case for at the age of 36, the resection of the endometrium and resection of the myoma, and
Yes,
see
sir.
how it goes. And otherwise, we have to go for surgery.
Yes, sir.
Thank you very much.
Thank you,
Well,
sir.
So one thing is that uterine artery embolization, that is very costly, and
Yes,
should
ma'am.
the patients, I think, who can afford it.
Yes, ma'am.
But
Thank
yes,
you,
theoretical,
Harsh.
you should know that.
Yes, ma'am.
Thank you.
Thank you so much.
Sir, and thank you, Dr. Harsh, for joining
Thank
us
you,
today.
organizers, Gangaram, Dr. Mala, Dr. Harsha, Professor Ashok Kumar, everybody that organizing this PGCME. I believe it would be extremely helpful to all of the PG that are appearing. And it's a great pleasure that I'm here for last 3-4 sessions that I'm participating. It's a great pleasure for me. And we are doing on behalf of All India PGCME also, but it's great that I believe it should be of much help to all of you. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir, for your nice and encouraging words. And actually, Dr. Pooja for her nice case presentation.
Yeah, it is a difficult case, but again, then we have covered all
She presented very well.
Yeah.
Thank you, ma'am.
For
Thank
your
you,
information. Great.
Thank you, sir.
Thank you. Carry on.
Thank you. Thank you, sir.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Now moving on to the moving on to our last session.
Just wait. No, wait.
Ashok Kumar
Leave it to
will
me
give-
now. Yeah.
Okay.
Leave it
Thank
to
you,
me.
sir. Okay.
Yeah. Nothing is required in between. Yes.